Mr. Neeraj? Hello? Yes,
Yes.
ma'am. Yeah. Hello? हेलो
जी मैम बताइए।
हाँ, मैं बोल रही थी कि 3 वीडियोस लगानी है आपको मेरे स्पीकर स्पीच के बाद Day 3 की वीडियोस लगानी है। आपके पास है ना
हाँ, तीनों वीडियोस हैं।
तीनों वीडियोस? ठीक। Mr. Neeraj, can you please allow me to share my screen?
Yes.
Mr. Neeraj, is my screen visible?
Yes.
Yes, okay, thank you.
Screen is also visible and you're also audible.
It's sharp 12 o'clock. I welcome all the participants. Today on day 3 of pediatric COVID training, we will be discussing mainly on invasive ventilation, and it will be divided into two sessions, the pre-lunch session and the post-lunch session. And in the pre-lunch session, we will be discussing the basics, basically, the basic terminology, the modes, and the multi-para monitor. And as we all know that we all have learned in first 2 days the various indications for oxygen therapy. So on this day, after non-invasive and the patient fails, we'll be discussing basically on the invasive ventilation. I think it's 12 o'clock now. I think we should start our session. My regards to all my seniors, Dr. Chandrakanta ma'am, and all the respected participants. Today, the first session will be taken by me. I am Dr. Manisha Maurya, Associate Professor from MLN Medical College, Prayagraj. I will be discussing on the basic terminology of invasive ventilation. So let us see one by one the basic terminology, the settings which we see and set on a ventilator during invasive ventilation will be discussed. So the specific learning objectives are the concept of basic parameters of mechanical ventilation, the parameters that control oxygenation, the parameters that control ventilation, the video demonstration of how to set up a ventilator will be seen at the end of this session. Now, let us discuss one by one the terminologies. The first is respiratory rate or the frequency. Pihu, please. The respiratory rate or the frequency is the number of breaths the ventilator will deliver per minute. And the initial rate which we set on a ventilator, the respiratory rate which we send is according to the physiological rate for that age. For example, if we are setting a respiratory rate for a neonate, we'll be setting towards the higher side as we have discussed on day 1, the various physiological respiratory rate of various different ages. For neonates, we can set a respiratory rate of around 35 to 40 as the respiratory rate of a neonate is towards the higher side. And then if it is an infant, we can set a respiratory rate of about 30 to 35. If it is a child less than 5 years, we can set a respiratory rate of around 25 to 30. If a child is more than 5 years, then we can set around 20 to 25. In adolescent and adults, we usually set around 12 to 14. So whenever we start, at the start of setting, we should keep the respiratory rate as physiological as possible. And the titration of respiratory rate is done according to the PaCO2 level, that is partial pressure of oxygen. As respiratory rate determines the minute ventilation, thus it determines the carbon dioxide elimination. So whenever we want to titrate, whenever we want to have a eucapnic ventilation, we have to titrate respiratory rate. So if the patient's PaCO2 level in arterial blood gas oxygen is high, that it is beyond the acceptable range, or whenever it is causing the respiratory acidosis, PaCO2 level is causing respiratory acidosis, that is pH is going beyond, is less than 7.2, or when PaCO2 is more than 55, we have to increase the respiratory rate so as to keep the PaCO2 level towards the normal side, that is from around 35 to 45. Now, the next setting which we set on a ventilator is tidal volume. The tidal volume is the volume of air which is delivered to the patient during a ventilatory breath. And this tidal volume is usually set in a volume control mode. So we can set a tidal volume in a volume control mode, but in pressure control mode, we cannot set a tidal volume. As in pressure control mode, we usually set a PIP, that is peak inspiratory pressure. So in a pressure control mode, we can watch the tidal volume, the various values which the patient is getting on the ventilatory display unit. And we have to be watchful whether the patient is being delivered the tidal volume in the normal range, that is around 6 to 8 ml per kg. So whenever we are setting a tidal volume in a volume control mode, we have to set the tidal volume at 6 to 8 ml per kg. And in a pressure control mode, we have to keep monitoring the tidal volume on the ventilatory display unit, whether the patient is receiving the tidal volume, adequate tidal volume or not. So in a case of ARDS, we usually keep the tidal volume at a lower side, that is 6 ml per kg, as the higher tidal volume in a child with ARDS, as in case of COVID pneumonia, high tidal volume may cause barotrauma also. So we have to keep the tidal volume towards the lower side. Tidal volume is also determinant of minute ventilation, as the minute ventilation is the product of tidal volume and respiratory rate. The next setting which we set is FiO2, that is fraction of oxygen in the inspired air gas mixture. So whenever we are ventilating a patient, we usually don't give 100% oxygen. Although we can start with 100% oxygen initially, and once the patient has been stabilized with other parameters like pressures and tidal volumes, then we have to try to keep this FiO2 towards the lower side, that is less than 60%, as high FiO2 more than 60% may cause oxygen related toxicity and may not be good for the patient. So it is required to keep the FiO2 in the range of 21 to 100%, but once the patient is stabilized, try to decrease FiO2 to less than 60% as soon as possible. As we have seen that FiO2 improves the oxygenation, so its values are adjusted so as to keep the PaO2 level, that is partial pressure of oxygen, which we get on arterial blood gas analysis, and the SpO2 level towards the acceptable range. The acceptable range may not be the normal range, as the acceptable range of SpO2 is around 92 to 94% in children, and the acceptable range of PaO2 may be around 55 to 80%, but the normal values as in pediatric age group is around 80 to 100. The PaO2 level normal value is in pediatric age group is 80 to 100, and neonatal age group is 60 to 80. So we don't have to be vigorous in setting this FiO2, as high FiO2 may not be good. So whenever we want to adjust this FiO2, we have to keep this PaO2 and SpO2 in the acceptable range, and try not to keep FiO2 more than 60%. The next important settings we set on a ventilator is PEEP, that is positive end expiratory pressure. Positive end expiratory pressure is the pressure that is maintained at the end of expiration. The main function of PEEP is it improves ventilation perfusion matching and also increases the oxygenation. How does it does that? It does by decreasing the intrapulmonary shunt. The intrapulmonary shunt is the amount of blood which is going to the heart going to the lung from the heart, and is again reaching to the heart unoxygenated. So whenever the intrapulmonary shunt is more than 15% or 20%, there is very severe hypoxia in the patient. So whenever we want to decrease the intrapulmonary shunt to increase the oxygenation status, we can increase the PEEP, and PEEP improves the ventilation perfusion matching and decreases the intrapulmonary shunt. PEEP also increases the functional residual capacity, and by functional residual capacity is the amount of air which is left in the lung after normal expiration. So we always need some amount of air to be left in the lung after expiration, so that in each inspiration more pressure is not applied by the patient. So in a diseased lung, when alveoli are collapsed, PEEP is applied by the ventilator to recruit the alveoli, and thus it distends the patient alveoli. It increases the functional residual capacity and thus improves the lung compliance and the oxygenation of the patient. Let us see this diagram. In this diagram, there are three settings. In this setting, you can see this is an alveoli. It is a partially collapsed alveoli as the PEEP which has been given to it is not adequate. So we can see, although perfusion is good, the circulation is good, but the ventilation is not proper. So this is a case of ventilation perfusion mismatching. So let us see this diagram. In this diagram, the alveoli is over distended. The PEEP has been applied too much, or there may be over distension because of the disease pathology per se. So this over distended alveoli may cause compression of the vessels by distending it, and thus ventilation is adequate. But perfusion is compromised. So this is also a case of ventilation perfusion mismatch. Now let us see this alveoli. In this we have given adequate PEEP. So PEEP is adequate. So we can see in this both ventilation and perfusion are proper by giving optimal PEEP. But while setting a PEEP, we must always remember that high PEEP or inappropriately increasing the PEEP may cause over distension of the lung, and the over distension of lung will lead to decreased venous return to the heart. Decreased venous return to the heart will cause decrease in cardiac output and thus may cause hemodynamic instability or sudden fall in BP. So this thing has to be kept in mind. And a high PEEP may also cause air leaks as the alveoli may burst out and air leaks may happen. So pneumothorax and pneumomediastinum can also happen, and this thing has to be kept in mind while setting a PEEP or while increasing its setting. The usual initial setting of a PEEP is around 3 to 5 centimeters of water. And in a case of ARDS, one can start with a high PEEP as around 8 centimeters of water also. The next setting which we set is PIP, that is peak inspiratory pressure. Peak inspiratory pressure is usually set in a pressure control mode. So it is the highest pressure which is reached during the each inspiratory phase. Increase in PIP improves the oxygenation. In a volume control mode, we don't set a PIP, that is peak inspiratory pressure. We just monitor its value. So if we can find sometimes there may be a sudden increase in PIP in a volume control mode. So when this happens, we should always go and see whether there is some airway resistance. So it's sudden increase in PIP in a volume control mode in which we don't control with PIP. It is variable according to the lung compliance and the airway resistance. If we find a sudden increase in PIP in a volume control mode, then it indicates that there is some airway resistance. This airway resistance can be because of secretions, bronchospasm, or mucus plugs. And whenever we find this, secretions can be removed by doing suction, bronchospasm can be removed by doing nebulization, and the mucus plugs, obviously we can do nebulization and suction together to remove the mucus plugs. So this PIP is variable in a volume control mode, and we have to fix this PIP in a pressure control mode. PIP usually improves oxygenation, but inappropriately high PEEP, as these are pressure, may also cause air leaks and barotrauma. So this thing has to be kept in mind. Usually the initial setting is around 18 to 20 centimeters of water. One can see this pressure time graph. In this we can see clearly what is PIP and what is PEEP. PIP is the maximum pressure which is reached in one breath. So every time breath is delivered by the ventilator, PIP is delivered. And the PEEP is the baseline pressure which is maintained throughout the cycle. So whenever we are ordering this PIP and PEEP values to our juniors or to the nursing staff, we have to be clear whether what we are speaking about, whether we are speaking about PIP or PEEP, as both pronounce the same. Now, let us see the plateau pressure. Plateau pressure or P plateau is the alveolar distending pressure or the pressure applied by the ventilator to the small airways or the alveoli. So let us, for example, see if the ventilator has delivered a PIP. So while this pressure has been delivered, because of some airway resistance, the ET tube, the trachea and the bronchi, some pressure is dissipated, and the pressures which is reaching up to the small alveoli or the airways are the plateau pressure. So the plateau pressure is the alveolar distending pressure. It usually reflects the lung compliance and is kept below 30 centimeters of water. So whenever we are speaking about ventilation, we always, in a case of ARDS, we always go and look about the plateau pressure, and plateau pressure should not go beyond 30 centimeters of water. The plateau pressure we don't usually set on a ventilator. It is derived on the ventilator by doing the inspiratory hold maneuver. The inspiratory hold maneuvers, there are certain buttons on the ventilator, maybe a direct button on the ventilator panel, or you may find the inspiratory hold maneuver buttons in the tool section or in the setting section. So the inspiratory hold maneuvers are done for about 0.5 seconds to derive the P plateau. So whenever we are ventilating a child, we should always derive the P plateau level so as not to have a barotrauma, and the P plateau level should be kept below 30 centimeters of water. So let us see this diagram. In this diagram, we can see that the ventilator is delivering the P peak, that is peak inspiratory pressure, and because of airway resistance, the pressure which is delivered to the alveoli is P plateau. This is P plateau. Whenever we find a very wide difference between P peak and P plateau, we should always go and see whether there is some airway resistance, maybe because of secretion, some blockage, or some bronchospasm could be there. Whenever we find very high difference between the peak and P plateau, there should not be very high difference between P peak and P plateau. And in a volume control mode, when we find both P peak and P plateau has risen high, both have increased in value, then we have to go and see whether we have to, then it could be because of the poor compliance of the lung, and we should always be gentle in ventilating a patient who is having a poor compliance, as high pressure may cause air damage, air leakage, and barotrauma in these patients. Mean airway pressure or MAP. Mean airway pressure is the average pressure which is given by the ventilator on the respiratory passage during the ventilation. So it may also be defined as the area under the pressure time graph. So this is the area under the pressure time graph, and it's the average pressure which the ventilator is delivering to the respiratory passage. And the MAP is determined by PIP, PEEP, ventilatory rate, and the TI, that is inspiratory time. The typical MAP which is kept is around 5 to 20 centimeters of water. MAP is the main determinant of oxygenation. So let us see this diagram. We can increase the MAP either, this is the diagram which is showing the blue colored graph. This is the mean airway pressure, that is the area under the pressure time graph. This is the mean airway pressure, and mean airway pressure is the determinant of oxygen. So whenever we want to improve oxygenation, we have to improve the mean airway pressure, and to increase the mean airway pressure, what we can do, either we can increase, where is my cursor? Either we can increase the inspiratory flow, or we can increase the peak pressure, or we can increase the inspiratory time, that is we can increase the graph, or we can also increase the PIP, or we can increase the respiratory rate. So these are the 5 determinants by which we can increase the MAP, and MAP can increase the oxygenation. The best among this is PEEP, that is positive end expiratory pressure. Now next value is peak inspiratory flow rate, that is tidal volume upon TI. And it is the maximum speed at which the set tidal volume is being delivered by the patient. It is expressed in liter per minute. This peak inspiratory flow rate is usually set in a volume control mode, but sometimes in newer ventilator, we don't find this peak inspiratory flow rate setting. In those ventilators, the peak inspiratory flow rate is set at a default of around 60 liters per minute, but it may range from around 30 to 100 liters per minute. And this peak inspiratory flow rate is also used to shorten or increase the inspiratory time, as we can, by increasing the flow rate, the faster peak airway pressure can be reached, and thus it shortens the inspiration. And if we decrease the flow rate, it increases the inspiration. So we can manipulate the inspiratory time by peak inspiratory flow rate, that is tidal volume upon TI. The next is the setting of IE ratio. IE ratio is the ratio of duration of inspiratory time upon expiratory time. So IE ratio is mainly used to set inspiratory time and expiratory time. The normal IE ratio which is kept is around 1:2, and it should be kept as physiological as possible. So whenever we want to set an inspiratory time or expiratory time, we have to set the inspiratory time at a physiological inspiratory time for that age. For example, if we are setting an inspiratory time for a newborn, as we have discussed earlier, the newborn respiratory rate is towards the higher side, so the inspiratory time is towards the lower side. So the inspiratory time of the newborn, a normal physiological inspiratory time would be around 0.3 to 0.4 seconds. For infants less than 1 year, it can be around 0.4 to 0.6 seconds. For a child less than 5 years, it's 0.6 to 0.8 seconds. For child more than 5 years, it's 0.8 to 1 second. And for older people and adolescents, adults and adolescents, it's around 1 to 1.2 or sometimes 1.4. So these values are not always able to be remembered. So whenever we are setting an inspiratory time, we have to go and see the IE ratio and try to keep IE ratio towards the 1:2 ratio. We can also go around 1:3 or 1:4 in case whenever we are having a case of obstructive airway diseases like in bronchial asthma, or whenever we want to improve the ventilation of the child, we can increase the expiratory time. That is, we can have the IE ratio of around 1:2 or 1:3. But when we are increasing the expiratory time, we must always keep in mind that by increasing the expiratory time, more of the air is expired is from the lungs, and it may cause alveolar atelectasis. So this thing has to be kept in mind. High IE ratio can be kept in a case in obstructive airway diseases like in, or whenever we are suspecting any bronchospasm which is not improving, then we can have a high IE ratio, or whenever there is poor ventilation and we need to have a carbon dioxide washout, we can increase the IE ratio. And we can also keep the IE ratio to 1:1, or by increasing the inspiratory time. If we want to increase the inspiratory time, as is done to improve the oxygenation, as we have discussed in the previous slide, that inspiratory time will improve the MAP and MAP improves the oxygenation. So whenever we want to improve the oxygenation, we can increase the inspiratory time. And we can have the ratio of 1:1, but reverse ratio is usually not used. And while increasing the inspiratory time, we always have to keep in mind that it decreases the carbon dioxide elimination and may cause air trapping, and this air trapping will cause over distension of the lung, decrease in venous return, and various complications. So whenever we are increasing or we are setting the inspiratory time and the expiratory time, we have to try as far as possible to keep it as around 1:2 ratio. 2 less TI, as in a volume control mode, the set tidal volume will be delivered very quickly, and it will the pressures will reach too high, too suddenly. So it may cause barotrauma also. And too long TI, as we have discussed earlier, will limit the respiratory rate and may cause hypercapnia and carbon dioxide retention also. Now let us discuss the phase variables. The phase variables are the various variables which are used by the ventilator for operation. So ventilator is operating basically on 3 phases: the trigger, the limit, and the cycle. Trigger, as we have we are seeing in this graph, is what causes the inspiration to begin. So there has to be some stimulus given to the ventilator by which it will start each breath. So inspiration will start by the trigger. And B, this is the limit. Limit is what regulates the gas flow during the breath. So whenever we are limiting, for example, if we are limiting the pressure PIP, then the pressure will not go beyond that value. And if we are limiting the volume, the tidal volume, the volume will not go beyond the set tidal volume throughout the range. So Limit is what regulates the gas flow throughout the breath. And C, this is C, what causes breath to end. So these are the three variables upon which a ventilator works. Now let us see one by one the trigger. Trigger are what determines the inspiration to start. It is of three types: time triggered, pressure triggered, and flow triggered. Time trigger is when the breath is delivered once the preset time has been elapsed according to the set frequency as is seen in continuous mandatory ventilation. For example, in a continuous mandatory ventilation, if we have set a frequency of around 20, then the ventilator will deliver a breath at every 3 seconds. So it is time triggered. Now pressure triggered ventilator senses the patient inspiratory effort. We all know that whenever the patient inspired, there is a negative pressure created in the chest, in the lungs, and this negative pressure, this decrease in baseline pressure of patient inspiratory effort is determined by the ventilator. So we have to set a trigger pressure, so that ventilator determines that baseline pressure when the pressure goes beyond that, and then ventilator helps that triggered that patient's effort by helping the ventilation. Now the next is flow trigger. Flow triggered is ventilator senses the patient inspiratory effort in the form of decreasing baseline flow, or senses the inspiratory flow directly with the sensor at the patient airway opening. So whenever patient inspire, there is a flow of air inside, and this flow of air is determined by the ventilator, or during exhalation when the pressure goes beyond a certain lower level, the ventilator senses the inspiratory effort of the patient and then helps that inspiratory effort by giving the desired pressure or the volume to the patient. So as we can see, both this pressure triggered and flow triggered, these are patient triggered. Ventilator, the patient has started the ventilatory effort, and the ventilator senses the patient's baseline effort, either pressure or the trigger, and then helps that patient started effort and helps that patient breath to a certain level by giving a desired PIP or by giving a desired tidal volume. And this time triggered is basically machine triggered. The next one is the limit. Limit is what regulates the gas flow during the breath. If a variable, for example, pressure, flow or volume, is not allowed to rise above a preset value. For example, if we have set a pressure of about PIP of around 20, the ventilator will deliver the pressure throughout the ventilatory cycle in each breath. The breath will continue and the pressure will be limited to that 20, and the pressure will not go beyond 20. Or for example, if we have set a tidal volume of around 200, the ventilator will deliver the tidal volume of 200, or the tidal volume will be maintained at that value and will not go beyond that value throughout the breath. So the variable is not allowed to rise above a preset value during the inspiratory time, and it is the limit variable. So breath delivery will be continued, but the variable is held at a fixed preset value. Now let us see cycle. Cycle is what ends the inspiration. This variable is used as a feedback signal by the ventilator to end the inspiratory flow delivery, which then allows exhalation to begin. It is also of three types: volume cycle, pressure cycle, and time cycle. Volume cycle, as we can see, the inspiration ends when a preset tidal volume has been delivered. For example, if we have set a preset tidal volume of around 200, then after this tidal volume has been delivered to the patient, the exhalation will start. In pressure trigger, the inspiration ends when a specific airway pressure is reached. That is, if we have set a airway pressure of around 25, and when this airway pressure has been reached, the exhalation will start. And the third one is the time cycle. The inspiration ends when the preset time has been elapsed. For example, if we have set a TI, inspiratory time, of around 0.4 second or 0.6 second, the ventilation will start exhalation after 0.4 or 0.6 second, which we have set. The most of the pediatric ventilator is time cycle, that is after a certain time which we set, the TI. After a certain TI, that is if we have set a TI of about 0.6 second, after 0.6 second, the exhalation will start. And is flow triggered, the patient inspiratory flow is directly sensed by the ventilator and that breath is assisted by the patient, by the ventilator. Now, what are the practical application of setting all these terminologies? Either we have to increase the oxygenation or we have to improve the ventilation. The oxygenation is can be seen by either PaO2 level or SpO2 level. PaO2 level is seen usually in the arterial blood gas analysis. So whenever we are finding a patient oxygenation status is deteriorating or PaO2 is lower side, then we have to increase the oxygenation. For increasing the oxygenation, either we can increase the mean airway pressure or we can increase the FiO2. And among this, mean airway pressure is the most effective way of improving the oxygenation. And the mean airway pressure, as we have discussed in the previous slides, is determined by the 5 parameters: the inspiratory flow rate, the PIP, the PEEP, the inspiratory time, and the respiratory rate. And the best among these are the PEEP, that is positive and expiratory pressure. And we can also improve the oxygenation by increasing the FiO2. But while setting the FiO2, we always keep in mind that FiO2 more than 60% may not be good for the patient. It may cause oxygen-related toxicity. So we have to try to keep FiO2 level below 60%. So the next parameter is ventilation. Ventilation is in the cases in which there is poor respiratory efforts, as in case of say CNS involvement, when the child's respiratory effort is decreased, or whenever there is neuromuscular blockage, as in GB syndrome, or when the patient has so much tired that the child's ventilatory effort is poor, and it may cause carbon dioxide retention. So improve to decrease the carbon dioxide, that is to decrease the PaCO2 level. Either we can increase the tidal volume or we can increase the respiratory rate. So among these, we usually use respiratory rate as the tidal. By increasing the tidal volume, it may also increase the pressures, and high pressures may not be good for the patient. So among these, respiratory rate is the first one to choose to increase the ventilation. We will be seeing the various videos later on. Now, this is the diagram, a simple diagram of a ventilator. We can see this is the oxygen panel. This is the centralized air supply. In new ventilators, there are only the oxygen panel which is connected, and the air supply is given by the compressor which is attached to the ventilator. The compressor gives the air, and both this air and the oxygen is blended together in the ventilator, and it gives the desired FiO2, which we require either 40% or 60%, which can be manipulated in the ventilatory panel unit. And then this is the ventilatory display unit with various buttons, graphs, and various parameters which we manipulate. And we have to see the electric supply. The electric supply has to be always confirmed before calling a technician for any problem, as we have to give the electric supply to the ventilator, to the UPS, and to the compressor. The 3 electric supply has to be given to the ventilator so that it starts proper functioning. So whenever we are finding any problem in starting the ventilator, we always go and first find whether the electric supply is given, all the 3 electric supply is given to the ventilator or not. Then we can see the breathing circuit, both the inspiratory limb and the expiratory limb is there. There is flow sensor which is connected to the ventilator, and it derives the various values the patient is getting, and it is shown in the ventilator display unit. This is the HME filter, that is heat and moisture exchange filter. Heat and moisture exchange filter is used whenever we are not using a humidifier. And when we are using a HME filter, we always have to keep in mind that it has to be of the proper size, that is pediatric age group, when we are using in a child. And this is a test lung which is given by each ventilator, and this test lung usually is used in the starting to see whether the ventilator is functioning properly or not. And this is the simple breathing circuit. This is patient inlet, bacterial filter, it is optional. Then from the patient inlet, the inspiratory limb goes into the humidifier. In the humidifier, the air is heated and humidified. Heated to around body temperature, humidification is done about 100%. Then this heated and humidified air goes from the inspiratory limb to the Y piece. There is a water trap so that water vapor doesn't trap in the airways to avoid resistance. And then through the Y piece, Either we can attach the nebulizer if we want to nebulize the child, or we can remove it. Then we attach the flow sensor, then HME filter when we are not using the humidifier. And from the HME filter, it is connected either to the NIV mask, to the BiPAP mask, or to the ET tube, that is endotracheal tube. And then from the patient exhalation, whenever exhalation occurs, the exhalation air, the carbon dioxide goes from the Y-piece to the expiratory limb. Water trap is also there, and then you may have bacterial filter, may not have bacterial filter, then it goes to the ventilator. So this is the simple breathing circuit. Whenever we want to put a breathing circuit to a patient, connect the breathing circuit to the ventilator and to the patient, we have to have a simple knowledge. We will be seeing the various videos also. But whenever we are not able to connect this breathing circuit to the patient and to the ventilator, then we can ask the technician who is supplying the ventilator, as there may be some minute differences in one or the other ventilator, this breathing circuit. So we can ask the technician how to apply this breathing circuit to the ventilator and to the patient. The technician coming with the ventilator will have a demonstration while installation of the ventilator. Now this is the ventilatory display unit. We can see there is a on-off button. There is alarms. Alarm button is there whenever we are having any value is going beyond. We can have an alarm which we have set. This is a rotatory knob through which we set various parameters. These blue ones are the parameters which we set on the ventilator, and these black ones are the parameters which is derived by the ventilator. So whenever in a pressure control mode, if we have set, we can apply the inspiratory pressure, and this tidal volume is variable according to the patient's compliance and the resistance. So we have to monitor this tidal volume so as to keep it toward the normal side. And these are various graphs which we can see on the ventilator display unit. It gives some idea about what the patient is getting. These are the references from which participants can go and learn more about the topic. Skills to be enhanced are: it is important to understand and set all these parameters. Changes in these parameters should be done according to the patient clinical status. If the patient is improving, the SpO2 is normal, the PaO2 is normal, the carbon dioxide is normal, the acid base is normal, then we can decrease the parameters and wean the child, and this can be seen by the arterial blood gas reports that we have discussed earlier. Practical implication will be discussed in the mode section in the coming section, and the initial setting and titration will be taken further. My sincere thanks to all the contributors, to Shali ma'am, to Chandrakanta ma'am, DGME sir, all the panelists, and to the participants for listening. Thank you very much. Now we'll be seeing the videos how to set up a ventilator. Nishant, can you please display the videos? Neeraj? Neeraj? Mr. Neeraj? Yes.
हमने इसमें सर्किट और वेंटिलेटर है, और ये हमने इसमें सर्किट और टेस्लम तैयार करके रखा है। मैं आपको दिखा दूं, ये फ्रॉम द पेशेंट दैट इज एक्सपिरेशन एंड ये टू द पेशेंट दैट इज इंस्पिरेशन। ये फ्लो मीटर के लगे हुए हैं, ये वेरी सिंपली इट अटैचेस हेयर है स्पायरोमेट्री को, ये यहाँ लगे हुए हैं स्पायरोमेट्री। ये लाइन यहाँ अटैच्ड है, यहाँ पे हमने फिल्टर अटैच कर रखा है, और ये टेस्ला में अटैच है। अब मैं आपको बताऊंगा कैसे इस वेंटिलेटर को आपको ऑन करके चलाना है, यूज़ करना है एग्जैक्टली। तो इस वेंटिलेटर में आपके पास दिस इज द कंप्रेसर एंड दिस इज द यूपीएस। इन दोनों को बिजली की सप्लाई देनी है, करंट की सप्लाई देनी है, और ये है वेंटिलेटर। इन तीनों को करंट देना है हमको। वेंटिलेटर अपना करंट यूपीएस से उठाता है, तो वेंटिलेटर का जो सर्किट है वो यूपीएस में लगा हुआ है। कंप्रेसर और यूपीएस, इनका कनेक्शन हमने यहाँ दे रखा है। ये यूपीएस के लिए है, ये कंप्रेसर के लिए है, और वेंटिलेटर की इलेक्ट्रिक करंट वो यूपीएस से आ रहा है यहाँ पे नीचे इस पॉइंट से। ठीक है, तो आपको दो आउटलेट लगाने हैं और वेंटिलेटर का इनलेट आपको यूपीएस से लेना है। अब इसको कैसे ऑन करना है, ऑन करने से पहले मैं इसे ऑफ कर देता हूँ। वेंटिलेटर बंद हो गया, ठीक है। आपने कनेक्शंस दे दिए, आपने बटन ऑन किए। आप आएंगे यहाँ पे, पहले बटन को ब्रीफली प्रेस करेंगे। पहले यहाँ से कंप्रेसर को ऑन करेंगे और यहाँ से फर्स्ट बटन को ब्रीफली प्रेस करेंगे फॉर 10 सेकेंड्स। यहाँ पे आ जाएगा वोल्टेज 229 230 वोल्ट्स का। वेंटिलेटर की मेन स्क्रीन पे आएंगे, यू विल कंप्रेस इट, सेल्फ ट्रेस्ट एंड कैलिब्रेशन होगा। पास नॉब को प्रेस करेंगे, स्टार्ट दबाएंगे, स्टैंड बाई मोड पे है। अपना मोड सेलेक्ट कर लेंगे, आप जो भी मोड यूज़ करना है आपको। सपोज आपको हमें प्रिंसिपल मोड यूज़ करना है, आपने मोड के लिए आपने स्टार्ट कर दिया और इंश्योर करना पड़ेगा, लिए कंफर्म कर देंगे, ये स्टार्ट।
So we can see the test lung which is inflating and deflating. So this is a simple PM chaos which may be getting in to most of us in our hospital. Next video, please.
Hello everyone, today we will see about the mechanical ventilator, the parts of the ventilator, tubings, how to attach these tubing and how to start a ventilator, and the next part we'll see how to set the parameters for the pediatric patient. So this is the electronic ventilator which we are using in our ICUs. This is the main panel of the ventilator. Currently this is switched off. We have to switch on the ventilator from the back side. After connecting the charging port into the cable into the charging port and also the humidifier, and we'll connect the cable of the humidifier in the port and we'll start the ventilator. This will see the charging cable, lights of the charging cable are on. This is the button from which we'll start the ventilator. We'll press it for the long time and we'll see the main panel is getting displayed. It will take some time to for the main screen to come. Till the meantime we'll attach the tubings. So as all the ventilator we know, we have some basic tubings. We'll take the sterile tubing, either the fresh tubing which are coming in the market or the reusable tubing which have been ETO'd or sterilized. So after donning gloves and hand washing and donning gloves, we'll take out the tubing. This part which has a 3 plug, this is the expiratory tube.
Next video.
So these are the tubings. It has both inspiratory and expiratory part. So how to differentiate? The one with a thin, the white tubing generally with a thin inlet is the expiratory tube, and the blue one, other one is the inspiratory tube. So as we see, this is the attachment which goes on the patient end in the endotracheal tube, and this is the end which goes into the ventilator. So we'll start with the humidifier chamber. So this is the humidification chamber which will, as we can see, there is a line which gives us the level for the water, and only sterile water or distilled water is filled in the chamber. So this is our humidifier. We'll switch on the humidifier from this point. We'll push down the inlet and then gradually slide it down. So as a click sound has come, that means the chamber has properly fixed. Now we'll attach the tubings. So this port, this is expiratory port, and this is clearly mentioned here is expiratory. So the expiratory port will go into this. The second part, which is the short part of the inspiratory tube. So the one part goes into the inspiration as mentioned in here, like this, and the broad part goes into the humidifier chamber. So we'll put the humidifier chamber. This is the inspiratory port which is going from ventilator to humidifier. Second part will come from humidifier to the patient end. So this is the second part of the inspiratory limb from humidifier. The broad end will goes into the humidifier chamber and the second part into the patient limb. For timing, we'll attach the patient limb to the test now. There is one more tube which is oxygen tubing. This is attached from this proximal end of the ventilator up to the distal end of the expiratory limb. This is the point. Okay, so this is our tubing. Now comes the humidification. So for the how to attach the humidifier, since we have switched on the humidifier, it is showing us the temperature. These are two modes, the invasive mode and non-invasive mode. Since we are doing the invasive ventilation, we'll select the invasive mode, and these two wires are there. So where to connect which wire? Since there are three ports, as you can see, we'll connect this proximal end into the inspiratory one, like this. The second part goes into the expiratory limb here, upside. Now the second tubing, the below one, as you can see, it has a blue point and has a cone-like thing here. So this cone get attached into the inspiratory limb. As you can see, there is a conical part for this blue thing. So we'll attach it here like this. Next comes its distal part. This is conical form, and this get attached into the inspiratory limb. So our inspiratory limb is humidified and heated. Now coming to the ventilator. So after attaching to the main source, we'll attach the air and oxygen. So from behind, please come behind. So on the back side of the ventilator, as you can see, it's clearly mentioned the oxygen port and the air port. So when we'll trace down the air port, this white port is the oxygen port. So as we'll see, this white tubing will connect into the oxygen like this. We have to plug it down and then push. Similarly, air will plug it down and push. Second thing which we will see on the back side is the flow sensor. So from here, the flow sensor wire is connected and it is then connected on the patient end like this. Now we'll start the ventilator. As we have switched on, this is the first screen which we see on the ventilator panel. We'll see the audio test. It is making sounds. Yes, we are able to hear the sound. Now here comes the second screen. Now we have to select which are we dealing with, the pediatric, like neonatal age group or pediatric age group. So if we are here dealing with the neonatal age group, less than 10 kgs, well, and it's about the flow sensor. So how to calibrate the flow sensor? So we'll take the flow sensor, we'll block both of its end or with our palm, and then do the flow calibration. So as you can see, a green line has came and is saying it's calibrated. We'll go on the main screen. I will connect it back. So this is the main panel. On main panel, you can see there are multiple things which is coming, and these are the modes. On baseline, you can see there CPAP, nasal CPAP, dose CPAP, oxygen therapy. These are basically non-invasive modes, and the upside is control mandatory ventilation, assist ventilation, SIMV, SIMV plus PSV and PSV. These are basically the invasive modes which we can give in the patients. Depending upon the modes, there are the control panel. There are the parameters which we can control, like the flow, trigger, I time, E time, the frequency, this FiO2, PIP and PSV, PEEP, oxygen, and volume limit. And this is the graph we can see depending upon what parameters we are seeing, whether the pressure, volume, or flow. So one by one, I'll tell you what settings which we are needed to set for different parameters.
I think these were the simple demonstration or videos of how to set up a ventilator. So whenever we are not able to set the ventilator, we can ask the technician how to apply the various tubings, because different ventilators have different way to put these tubings, and there are two types of tubings also. One is disposable and one is reusable. So there are some difference between these two. So we can ask the technician. We can easily identify how to apply these ventilator. So I don't find any questions in the question answer session or in a chat box also. So I think we can go to the next session. Next session is will be delivered by Dr. Payal Mittal from FHMT Firozabad. She will be discussing about multi-para monitor. Dr. Payal,
Hello, Dr. Manisha.
Dr. Payal, over to you.
Yeah. Can I share my screen?
Yes.
A very good afternoon to everyone. My topic is to discuss multi-para monitors. For this, our learning objectives are different. In multi-para monitor itself, it shows we are seeing multiple parameter in a single monitor, and how to use it and how to set alarm settings and maintenance of the device. It simultaneously measures and display the relevant vital parameters in sick child. In general, basic models are used to monitor cardiac activity by ECG, heart rate, and oxygen saturation by SpO2, NIBP, that is non-invasive BP monitoring, respiratory rate, and temperature. It consists of sensors. Sensors are connected by the communicating link and processing devices and display. Additional specification according to model and makers. There are multiple brands are available like Minray, GE, Philips, Draeger, Silverline, Meditech, and so on. There are different monitoring domain. In cardiology, we are seeing ECG, cardiac output, continuous cardiac output monitoring, impedance cardiograph, airway and gas in lung mechanics, in respiratory mechanics, and AG, neurology, EEG, and NMT. In hemodynamics, mainly we are seeing these ECG, and in hemodynamics, IBP or NIBP, that is invasive BP monitoring and non-invasive BP monitoring. For oxygenation, SpCO2, SpO2, and pulmonary perfusion index. There are certain monitors in which we can see RSO2, means regional saturation of oxygen. We can see saturation of brain, kidney, etc. There are different kind of very higher grades of monitors. Temperature. These are the parameters we are generally seeing: ECG, respiratory rate, SpO2, temperature, non-invasive BP monitoring, invasive BP monitoring, central venous pressure, EtCO2, EEG, and regional oxygen saturation. Cardiac output, continuous cardiac output monitoring, central venous oxygen saturation, neuromuscular transmission, impedance cardiograph, bispectral index, respiratory mechanics, and transcutaneous blood gases. In ECG, we can use 3 lead, 5 lead, 6 lead, or 12 lead ECGs. In general, in NICU and PICU, we generally use 3 lead ECG. By ECG, we can get heart rate as well as ECG. Arrhythmia can be detected by this, like hyperkalemia, hypokalemia, any kind of arrhythmia, asystole. Sometimes when child is moving, we cannot pick it by a pulse oximeter. We can see heart rate if there is any decrease or increase. Arrhythmia monitoring is intended for adult and pediatric patients. ST segment analysis, QT analysis, and for 3 lead ECG, we have to place one in right arm at directly below the clavicle and near the shoulders, and in left arm directly below the clavicle and near the left shoulder, and left lower limb placement on the left lower abdomen. This is how the ECG will work.
And the second part that is connected to the cable and the ECG leads that have to directly attach to the baby. Usually we go for the 3 lead ECG with the left part, right part and the lower limb component that has to be attached. We can also attach to the lower left abdomen of the baby. Leads has to be attached to the baby with the electronic pads. After connecting the lead to the baby and to the monitor, there is a direct display of the ECG on the display monitor, and we can directly assess the pattern of the ECG of the baby, involving the assessment of the any electrolyte imbalance or arrhythmia. ECG leads also give a heart rate of the baby, and in the setup we can select lower limit or upper limit of the heart rate according to the age of the baby and directly involvement and assessment of baby. Thank you. ECG
Respiratory rate. Respiratory rate can be derived from CO2 monitoring or impedance by ECG leads. By placing the impedance, respiration is acquired using standard ECG electrode and cables. Either lead 1 or lead 2 can be used for it. Pulse oximetry. By pulse oximetry, there are different kind of pulse oximeters, and by pulse oximetry we can see 4 parameters: SpO2, perfusion index, PVI and SIQ. SpO2 is measure of oxygen saturation. Saturation target for pediatric patient is more than 92%, and in neonatal, in neonates, it is 90 to 95%. It shows numeric as well as graphical display. Probe placement should be in right upper hand in neonate. It has to be avoided where the BP cuff is put, because whenever the BP cuff inflated, it gives us a false reading. Changing of probe site is important, and ear probes are also available. PI is perfusion index. This is an indicator of peripheral blood flow. It measurement of strength of photoplethysmographic signal at the sensor site. Its normal value is 0.02 to 20%. In some monitor it will show here, in some monitor it will show here. This 1.1 is normal. It is 0.02 to 20%. 0.02 means very weak pulse and pulse strength, and 20% is very strong pulse strength. PVI is plethysmographic variability index. It measures changes in PI during respiratory cycle. It helps in assessing hemodynamic significance of PDA and intravascular volume status in neonate. High PVI in hypotension indication of flu bolus. Basically, more than 14% PVI shows child is hypovolemic. We have to give some fluid. It can predict responsiveness in infant undergoing congenital heart surgery. SIQ is signal IQ indicator, quality of flow to area applied and enhanced signal quality. This is the SIQ. This is a good SIQ. By this we can see a good plethysmograph, good SIQ and good pleth. Here is poor SIQ. There is no graph is here, and inconclusive breath. Here the SIQ is good, but the pleth is variable because of moving artifact. Here is good SIQ and non-variable low pleth. It shows a low volume pulse. Temperature can be thermally taken by thermally sensitive resistor, that is thermistors are used. The resistance change of thermistor is used to calculate the temperature. Up to 2 temperature sites can be monitored simultaneously, and the difference between the 2 measured site is calculated. Rectal temperature monitoring also possible with special probes. NIBP is non-invasive BP monitoring. Basically, it uses oscillometric method based on principle that pulsatile blood flow through an artery create an oscillation of arterial wall. oscillometric method basically measures mean blood pressure, and it calculates systolic and diastolic pressure. There are different sizes of, in pediatrics we are having different sizes of arm circumference. There are different sizes of limb circumference cuffs. The width of the cuff should be 40% in neonate and 2/3 of the length of upper arm and thigh in children. Inflatable portion should cover 60 to 80% of arm length. Application of cuff should be such that artery marking should be at appropriate places. It should be smooth and snugly fitting. Always choose auto inflate option. Average of 3 reading is ideal. Uh, um, do not take in crying or agitated state because it will give fallacious reading. These are different sizes of cuffs available. Now the video.
For the blood pressure monitoring of patient, we have this non-invasive blood pressure monitoring NIBP cable with the one end attached to the module, and the second end will attach to the disposable BP cuff. And BP cuff is available in the different size depending on the baby's age and the weight. After connecting the cable and cuff to the baby, we will start measuring of blood pressure by pressing the knob or touching the screen. That option is available in the monitor. And frequency of measurement of blood pressure is can be manually, or it can be set in the according to the requirement, from varying from 5 minutes to every 2 hours. That automatically the monitor will assess the blood pressure. While the measurement of the blood pressure, the reading will be there, and ultimately at the end the blood pressure with systolic, diastolic and mean will appear on the monitor. In this baby, the blood pressure is the higher range, so alarm is blinking. For the alarm setter, we touch the parameter and the separate window will pop up, and according to the gestation of and age of the patient, we can decide the low and high for each systolic, diastolic and mean blood pressure.
Invasive blood pressure monitoring. Invasive blood pressure monitoring has to be done in critically ill patient. It shows us a real-time recording, and both numerical and waveform are available. In invasive BP monitoring, there are a few things required: pressure bag, IBP module, IBP cable, IBP transducer, and 3-way valve. In this, we have to cannulate an artery, either radial or femoral. Most of the time, we use radial artery for cannulation. This is pressure bag, and this is IBP module. From this IBP module, there is a connection that is IBP cable. This IBP cable is connected to the IBP transducer, and after then this is connected to this 3-way to measure the BP blood pressure. These are the components required: pressure bag, IV line, IBP transducer, IBP cable. The component of arterial waveforms, there are 4 components of arterial waveform: peak systolic pressure, dicrotic notch, diastolic pressure, and anacrotic notch. Peak systolic pressure, this is the peak systolic pressure. This we call it as a systolic pressure. This is dicrotic notch. This occurs due to opening of aortic valve, closure of aortic valve as a result of backflow from already existing pressure in aorta. This is the actual waveform. This is diastolic BP. This is systolic BP. This is dicrotic notch. In the other waveform, we can see this hole is the systolic BP and this hole is the diastolic BP. Here aortic valves open, blood rush to the peripheries, and pressure increases as blood flow into the aorta. This is here the aortic valves closes. This is dicrotic notch, and pressure falls as blood flow out of the aorta. EtCO2. EtCO2 is capnography, is the graphic display of CO2 concentration versus time or expired volume during a respiratory cycle. Capnograph is the machine that then generate a waveform, and the capnogram is the actual waveform. Here we start with the there are 2 kind of CO2 sensor. One is mainstream sensor and other is side stream sensor. In mainstream sensor, the sensor is directly attached to the endotracheal tube. Sensor is attached to endotracheal tube, then it is attached to the display, and one end is attached to the display and other end is attached to the circuit. In side stream sensor, endotracheal tube is connected to the sampling adapter. From sampling adapter, there is a sampling tube which is attached to the sensor and display. And in this sampling adapter has a two opening. One is attached to the sampling tube and other is attached to the circuit. In EtCO2, we are starting with the expiration, not with the inspiration, as the CO2 increases during expiration, not in the inspiration. As here the expiration begins, there is no CO2. As the expiration increases, this is alveolar plateau. CO2 reaches uniform level. The height of the plateau is related to the cardiac output. This is the first phase where there is no CO2, expiration begin. In second phase, rapid rise of CO2 as the air from alveoli containing CO2 reaches upper airway. This is the third phase. This is the alveolar plateau. This is CO2 reaches uniform level. The height of the plateau is related to the cardiac output. This is reading is showing in the R monitor. This is EtCO2. This is the maximum CO2. Here the inspiration start and the CO2 become 0. These are the different waveforms of capnogram. This is sudden loss of waveform. If there is this is the waveform, there is sudden loss. It shows either ET tube disconnected, kinked or obstructed, or loss of circulatory function. And here is the initially this is the waveform. This is decreasing EtCO2. It could be due to ET tube cuff leak, ET tube is in hypopharynx, or there is a partial obstruction. It can be, capnogram can be used for assessment of CPR. When we are doing CPR, attempt to maintain minimum of 10 millimeter of mercury of CO2. A sudden increase in PCO2 while doing CPR, this is return of spontaneous circulation. That means we are successful in resuscitating the child. In bronchospasm, there is a shark fin appearance. Like in asthma and COPD, hypoventilation, child is respiring, the width increases. In hyperventilation, width is decreased. Decreased EtCO2 is in apnea or in sedation.
For the end tidal CO2 monitoring, we have a separate microstream sampling line that take the sample from the exhaled air and send it to the sensor that present in the separate module. In this Paediatric 19, we have a separate module that put into the satellite unit, and the sensor is present in this module. After inserting this module into the satellite unit, we have to plug in the microstream sampling line with one end to the module and other end connected to the baby, depending upon the baby on the invasive or non-invasive mode of ventilation. For the invasive mode of ventilation, we have a hub with connector to the ET and other end to the ventilator circuit. For the non-invasive mode of ventilation, we have a nasal cannula microstream sampling line that can be used for the baby. After connecting the sampling line, EtCO2 number will display on the monitor, and then we can regulate the baby's ventilation status by assessing the end tidal CO2 more frequently with the non-invasively, and ultimately that will increase the frequency of ABG and decrease the sampling of the baby.
There are different alarm setting according audiovisual alarms, heart rate depending upon the age, respiratory rate also depending upon the age, BP depending on the age, SpO2 is 90 to 95% for newborns and more than 92% for children. Temperature is between 36.6 to 37.6. ECG for arrhythmia. Now the maintenance of cables and the device. Extension cable should be tucked up in a bag when not in use. Disposable, ideally we have to use disposable accessories as much as possible. If you are using a reusable accessories to be cleaned with the spirit swab in between, accessories when not in use should be kept in labeled boxes. So the key message is real-time monitoring of all the parameters, use the sensors properly, set age-appropriate alarms, Early warning of adverse changes or trends can be picked up by the monitors and response to therapeutic intervention. It reflects proper functioning of other equipment too. These are the references. Skilled learned are understand the various parameter, identify compatible and appropriate sensor, identify and interpret abnormalities, set alarm limits. The most important monitor is clinician. Remain vigilant, integrate monitor information into patient care. My sincere thanks to all the contributors. Thank you.
Thank you. Thank you very much, Dr. Payal. It was a nice presentation
Thank you.
and well explained. I'm not able to see any questions either in the question answer session or in the chat box. So I think we will proceed the next session. The next session is on indications and modes of ventilation, and it will be taken by Dr. Anita Singh, STPGI from STPGI, Lucknow. Over to you, Dr. Anita.
Is my screen visible?
Yes, yes, it is visible.
Okay. So thank you very much for inviting me for the lecture. So in this module, we would like to know about the indication and modes of ventilation. So learning objective of this presentation would be indications of ventilation, causes of respiratory failure. We should need to know understanding of the different modes of ventilation and how to choose an appropriate mode in a baby who is having respiratory failure. So in the case of normal respiration, the purpose of respiration is to get our blood oxygenated and the CO2 to be eliminated. So in the case of respiratory failure, these two processes are hampered, leading to failure of oxygenation or failure of carbon dioxide elimination, leading to different type of respiratory failure that we know as a type 1 or type 2 respiratory failure. Let's come to the causes of respiratory failure, and I would say it can be very well recapitulated in terms of the respiratory pathway. We need to understand that our respiration starts with the signal from the brain, which goes to from the spinal cord to the intercostal nerves and intercostal muscles, and then the muscles moves, and in the alveolar level oxygenation occurs. There are various anatomy. There could be problem with the airway, there could be problem with the alveoli, there could be problem with the pleura, and in that way we can understand what could be the various causes of respiratory failure. So let us start with the brain. In the case of once we start with the respiratory center, there could be poisoning which can lead to the suppression of the respiratory activity, or could be brain injury. In the spinal cord, there could be injury, or there could be a neuropathy, or there could be encephalomyelitis or polyneuritis. In the peripheral nerve, Guillain-Barré syndrome is one of the very common situation which we see frequently. There could be neuropathies. In neuromuscular junction, there could be myasthenia gravis and botulinum toxin, which can hamper the neuromuscular junction integrity. Then in respiratory muscle pulse involvement, it could be also because of the myopathies. In the airway, common situation is asthma, which is reversible and comes in form of episodic, but then it can be a very severe presentation, which can require even ICU admission. Then in alveoli, which there could be infection leading to pneumonia. There could be ARDS, which could be because of the infectious or non-infectious cause. There could be blood which may be irritating to the alveoli exchange. That could be pulmonary hemorrhage. And the encasing pleura may be occupied with the air or fluid, leading to pneumothorax and effusion, and which subsequently keeping on the compression of the lung and hampering the ventilation. So once we know the causes of the respiratory failure, how to identify a child in respiratory failure. In previous 2 days, we have understood about the vital signs and how to identify a sick child. Coming to the respiratory system, when a child in respiratory failure or respiratory compromise presents clinically as either increase in respiratory rate or uh, there could be a problem with the breathing. There could be increased work of breathing. They could be feeling difficulty in breathing. So what we call as tachypnea and dyspnea. Then accessory muscle use can be there in form of nasal flaring or suprasternal and retraction. There could be chest indrawing in form of subcostal retractions. There could be visibly apparent bluish discoloration that we call as cyanosis because of the hampering of the oxygenation. The tachycardia, bradycardia, and sweating are the secondary effects which can hamper because of the prolonged hypoxia and increased work of breathing, leading to the cardiac compromise and compensation in form of tachy or bradycardia. The voice could be feeble in cases of problem with the upper airway or even in the lower airway. There could be a problem with the laryngitis, which can result in the change in voice, or the voice could be feeble even in case of neuropathies, which especially in case of GBS also. There could be a hyper and hypotension again, which could be a manifestation of the further prolonged tachypnea or respiratory failure leading to secondary cardiac compromise. They could be in the respiratory system examination per se. On the auscultation, we may find diminished breath sounds or absent breath sounds. And adventitious sound in form of scripts and rhonchi can further delineate the problematic pathology. In investigation, the bedside pulse oximetry is easiest and earliest quick tool which can assess your oxygenation, and SpO2 of 92 to 94% at room air is a significant thing which we need to see. Then again, the blood gas analysis in the facilities whenever available, it can again give you result in a few minutes, and you can find in that hypoxemia if your PaO2 is less than 60, and that 60 is too less for a child, that is for the neonates, but for the child it can be taken as a 80, and that PaO2 of more than 50 as a case for the hypercapnia. So both of these values show the impairment of oxygenation and ventilation that we discussed in initial slides. Then again, we can have chest X-ray and CT scan further, for further understanding of the disease. So once we have a pair as a child comes in with respiratory failure, and we have a quick assessment of the respiratory status. So if we feel that there is only hypoxia with the involvement, then we can proceed straight away with the oxygen. In fact, oxygen is the first thing which we apply for the child who comes in the respiratory embarrassment. Then if along with the hypoxia, there is hypercarbia with fair spontaneous effort, and child is speaking well and looks better and is responding, then you can proceed for the non-invasive modes of ventilation. But if there is a severe hypoxia or hypercarbia with poor respiratory effort or poor neuronal integrity, in that case, one should proceed for the invasive ventilation. So goals of mechanical ventilations are oxygenation and ventilation. Oxygenation is determined by mean airway pressure and fractional oxygen concentration, which we have discussed in the what are the initial parameters. So with the overall PIP, PEEP, and TI and flows, we get the integrated mean airway pressure, which is something which is the most important thing to determine the oxygenation, how your ventilation is going to affect the clinical condition, and along with the FiO2. If we have to hit on the ventilation, we should keep on fine-tuning over the frequency and keep a watch on the tidal volume and minute ventilation. So coming to the conventional mode of ventilation, there are various mode of ventilation. So first is the controlled mandatory ventilation, then assist controlled ventilation, then synchronized intermittent mandatory ventilation, support ventilation, and pressure controlled ventilation. We will see one by one. So this is the basic anatomy of ventilator, which you have all must have seen in the previous lectures, that oxygen and air comes, which gets blended inside the ventilator. then through the inspiratory valve, and there are various flow transducer and hemotachometer by which these are the sensing and trigger mechanism, and it initiates the breath and it goes to the lung. And the exhalation is controlled by the expiratory valve or PEEP valve, which also adjusts for the regulation of PEEP. And like once exhalation of valve open, the exhalation occurs. So first is the controlled mandatory ventilation. As the name suggests, controlled mandatory ventilation. The breath has to be mandatory and it has to be controlled only by the ventilator. So in this ventilation, all parameters are controlled by the ventilator and patient cannot trigger the ventilator. But it has several disadvantages, and I would say that this is something which is which no longer anyone prefers these days. So it can be useful only in a child who is having no neurological activity or having deeply sedated. In case a child wants to take a spontaneous effort, there could be problematic synchrony in both the phases of respiration. So it requires heavy sedation and muscle paralysis, and that is something which none of us would want to. So in this case, everything is getting controlled by the ventilator. You can see there is no trigger fluctuation. This is the pressure limit, and flow, expiratory, inspiratory, everything is controlled by the ventilator. Then coming to the assist control ventilation. In this mode, patient can trigger the ventilator, but once triggered, all the parameters are supported by the ventilator. So in this case, this mode, the control of initiation of breath is to the patient, but subsequent what pressure is to be achieved, what PEEP is to be applied, at how much frequency the breath are to be given, everything is determined by the ventilator. So in that case, this is something which we would like to give to the child when your child is having severe illness or initial phase of illness, when you want to support each and everything. But there are disadvantages, that there could be possibility of hyperventilation because of all the efforts are getting assisted, and if you don't titrate your pressure according to the ventilation and blood gases, there could be problem with the hyperventilation, and each and every breath is supported by the pressures which we set. Still, there could be asynchrony between various phases of respiratory cycle because the overall rate is being set by the physician, and trigger is being given by the baby. So only initiation of breath is being controlled, but at the other phases of respiratory cycle, there could still be asynchrony. Then coming to the synchronized intermittent mandatory ventilation, this mode of ventilation is pretty good, and it is one of the commonest and easiest to understand mode of the ventilation. In this ventilation, only a fixed number of breaths are assisted by the ventilator, and patient is free to breathe in between the during expiratory pause. So here you can see that this is a trigger which is initiated by the patient. So all these assist control, synchronized SIMB, these are patient triggered ventilation. So the breath would be initiated by the child, then it will give the child a set pressure level at a breath which is we have set, but in between the breath, you can see a spontaneous breath. The magnitude of this breath is smaller than what we want with the ventilatory assistance. Obviously, the child is sick, so he cannot augment the huge effort in the spontaneous breath, but the child is allowed to breathe in between. So these two are mandatory breath, and in between the child is being allowed to have a spontaneous breath. So there is some comfort at the patient level. And this mode has advantages and disadvantages too. So patient can breathe spontaneously between the mechanical breaths. Ventilator support is tailored to the patient demand. It can facilitate weaning because as patient is being allowed to breathe, so over due course of the time, the amount of magnitude of spontaneous breath effort will increase. As we want to allow the child to breathe, we would require less sedation. And of course, once the child is breathing in between, there is a preservation of a spontaneous respiration, because if you control the respiration on ventilator for a longer period of time with sedation and paralysis, the spontaneous efforts wanes off, and it takes a lot of time to regain the efforts by the child. So in that case, this mode is good, that it assists as well and keep the child to retain their spontaneous effort simultaneously. The disadvantage is that, again, if your child is in severe respiratory distress, in that case, you would like to support each and every breath. So in that case, spontaneous breath may not be desirable, and you may like to switch the child on a assist control mode. Then obviously other problem of the ventilator would be still be there. There would still be expiratory asynchrony. So coming to the next mode, that is pressure support ventilation. So in case of pressure support ventilation, the inspiratory support, pressure support is applied to spontaneous breaths to eliminate additional work of breathing. So in this mode of ventilation, we depend on the child to initiate a breath, but only the breaths would be supported to a set pressure level. So the rate is again completely determined by the child in this case, and it may be used as an independent mode itself, or it can be integrated to SIMV with the pressure support for the spontaneous breaths. So in this case, patient will initiate a breath. Once it exceeds the trigger sensitivity, inspiratory flow and set pressure level would be achieved. So this is a kind of pressure support ventilation. And the parameters which we want to set are trigger, set pressure level, and PEEP and FiO2 as we do in other modes. So this mode has advantage that it preserves the patient spontaneous effort. Patient has a control on all phases of respiratory cycle. So here we are not going to have any asynchrony. In the assist control and in SIMV mode, we were still having respiratory asynchrony, but it becomes child friendly or patient friendly. But again, this should be only used when we are sure that the child has sufficient respiratory effort to sustain. Again, the disadvantage would be variable tidal volume and minute ventilation because of varying leg mechanics with the patient effort. But then we need to know that at what level we should start with the PSP. So obviously, we are not going to use at an initial stage of illness when the things are severe, but we can do this very well as integrated mode or as an independent weaning mode. Then we should now we should again after all this we should again understand that what is PCV and what is BCV. So the mode can be controlled depending on the where the control of the trigger is, who is initiating the breath, whether the patient is initiating the breath, whether the ventilator is initiating the breath. But what is the limit? The limit of the lung mechanics, whether it is a PIP that happens with the pressure controlled ventilation, or whether it is a tidal volume that happens with the volume controlled ventilation. So depending on the limit or depending on the what limit we want to control in with us, we have pressure controlled ventilation and volume controlled ventilation in all controlled mode of ventilation. So coming to the pressure controlled ventilation, we need to understand that ventilator delivers an inspiration at a set pressure level for a prefixed time, and the tidal volume is variable and is determined by lung mechanics. So in this case, we want to achieve a pressure which is set by us, and we control that in all breaths. If you want a PIP of 18, the PIP of 18 would be delivered. But in the breath to breath, the tidal volume may not be same by that PIP of 18. So in all breath, our set pressure level would be controlled. It has advantages and disadvantages. So advantages are limitation of airway pressure to that we can set our pressures to non-barotraumatic level, and risk of pneumothorax will decrease. And we can better control the PIP, so we can better control and fine tune our mean airway pressure, because it is one of the important determinant of the mean airway pressure. The disadvantage is that variable tidal volume. So again, once you control one, the other will vary. If you control pressure, the volume will vary. So then we have a risk of volume trauma. And again, if your pressures set are too high, it can lead to hemodynamic dysfunction. So coming to the volume controlled ventilation. In the volume controlled ventilation, what we control, what the limit is the tidal volume. We tell the ventilator that in each breath we want to achieve this set tidal volume, and the ventilator would achieve that tidal volume, but it will vary the pressure from breath to breath. So you can see that at the lowest graph, we have tidal volumes, and they are the constant. They are controlled, and they will remain unchanged irrespective of the lung compliance. But with each breath, the pressure may vary, right? One more important part of the volume controlled ventilation, that in these cases, our flow waveform, which is square waveform, you must have saw in previous slide, there was a sloping waveform. So in volume controlled ventilation, often there is a square flow is also controlled, and it comes as a square waveform. So coming to the advantages of and disadvantage of VCV. So again, we want to achieve volume limitation. So it releases the work of breathing and ensures a minimum tidal volume. It again has disadvantages that the pressure would vary with the breath to breath, so it can lead to barotrauma. And pressure flow demands may be high because of the square waveforms. So this is a slide which I have kept to just to understand that in so you can see that in the pressure controlled ventilation, this is a constant pressure which we are getting, and our flow is like this accelerating or decelerating sloping waveform. But in the volume controlled ventilation, the pressure would vary. So it remains like this. It goes to the peak, then maybe plateau pressure. And the flow is in the form of square waveform. After understanding all the modes of ventilation, it is very important that we keep all the alarms. We learned in the previous presentation that we have to put the alarms in the multi-para monitors simultaneously. In all the machines, there are option of the alarms, and alarms should be appropriately respected and always put. Just setting the ventilatory parameters is not enough. So we may need to set our alarms for the respiratory rate, for the tidal volume, for the minute volume, for the airway pressure, for the FiO2. The things which are constant will remain constant as respective to the mode. So say you go for the VCV, your tidal volume would be the constant, but then you set the alarm for your peak pressures. In case of your pressure controlled ventilation, your pressure would be constant, then you set the alarm for your tidal volume. So the key message for the this lecture would be that synchronized and pressure triggered ventilation are preferred most of the times. In sick children, you can start with assist control mode of ventilation. In mild to moderate illness, you can straight away proceed with the SIMV. Again, at the end, you should choose a mode in which you're confident, and I would say that SIMV is a wonderful mode, and it can be simply learned with by all. And always monitor the delivered parameters. You set some parameters in some modes, but there are parameters which are derived from the ventilator according to the mode. So always monitor your delivered parameters, like what is the tidal volume, what is the mean airway pressure, whether what we have said that is being delivered or not. So look for the graphics if at all available. If not graphics are available, then go for the delivered parameters values, numerical values, and see, and always set alarms and respect also the alarms. So at the end of this presentation, we should be understanding the different types of mode. We should be able to choose a mode depending on the respiratory condition of the child. We should be setting the parameters appropriately. We should be analyzing the displayed parameters in form of the graphics or numerical values. And again, it is not just the machine. Always monitor the ventilator patient synchrony. Not just setting the parameters is not enough. Look for the chest exertion, look for the comfort of the patient. Once you have put the child on the mode ventilator and have set the mode and parameters, the breathing should look comfortable. The child should not be exerting. It happens always that child is put on the ventilator and still child is exerting. So the work of ventilation is not achieved. So always monitor for the patient ventilator interaction. So thank you. These are the references.
Anita. It was a nice presentation. I think one question is there for you, which is the commonly used mode.
So the commonly used mode is, as I told, it is SIMV mode. Um Most of the people are comfortable with that mode. And apart from that, in the SIMV, we have to choose the PCV or VCV. In the smaller babies and in the newborns, most of the people in India are comfortable with the pressure controlled ventilation because of the ventilator requirements and the tubings, because the small volume adjustment and the flow sensor and the tubing adjustment are not possible in the newborns with the volume controlled ventilation. In the child, again, it varies. In the pediatric age group, in the SIMV, you may choose the tidal volume as a constant in the VCV, or you may choose the pressure controlled ventilation. I would say ventilation is something which is learned bedside. Once you see 10, 15 babies getting ventilated, then you will understand your comfort level. And the if I say for myself, I would say that the number of child I have managed on whichever mode of ventilation, I would go for that mode only. I would not experiment with the new modify at all. I am not at all comfortable. So go for one mode for 15, 20 babies, then start saying for another mode, and then things can be understood. So uh, the comfort of the and the confidence of the mode varies for the person to person. In the smaller baby, it remains as IMB pressure control mode of ventilation. For the child, it can be SIMB plus PSV with either pressure control or volume control. In the present module of the today, there would be subsequent there's subsequent presentation that how to initiate and how to set the parameters, in which we would one would be better understanding that how things are done in a child who comes sick with the uh, clinical condition. Then we can better understand that.
Thank you very much, Anita. I think
Thank you, ma'am.
this is the most common question being asked in every session, which is the best. And I think in smaller children, in units, we usually use basically between pressure control and volume control. Most of the people are confused among this only. And I think you have answered very nicely. I don't think we have any other questions. And we are ahead of time today. It's 1:37. So we will be having a break of about 20 minutes or more, and we'll be again assembling at 2 o'clock. So I think it's 20 minutes break is enough for everyone, and sharply we'll be reaching assembling at 2 o'clock with our new lecture on how to incubate a child. So thank you very much, everyone. Everyone, please gather and stay connected, and we'll start at sharp at 2 p.m. Dr. Kavita? Dr. Kavita, I think you have to start on at 2 p.m. because we have
Okay, ma'am.
finished.
Okay, ma'am.
We,
I'll be ready. Okay, ma'am.
okay. I was just searching your number, how to inform. Just you got connected. Thank God. You have to start at 2 p.m. Okay.
Okay, ma'am. Okay, ma'am. Hello?
I think next session can be started. The post-lunch session can be started from now. From now, Dr. Kavita Meena from IMS BHU Varanasi will be moderating the session, and the first session will be taken by her, endotracheal intubation in children. Over to you, Dr. Kavita.
Hello?
Dr. Kavita.
Good afternoon, everyone. I hope I'm audible and visible.
Yes, you are audible
I
and visible.
Okay, I'll start with my lecture. In this post-lunch session, we'll be discussing about endotracheal intubation in children. Our learning objectives will be understanding the key anatomical differences between pediatric and adult airways, comprehension of the equipment and preparation required for endotracheal intubation in children, and procedural step for performing endotracheal intubation. Overview of our presentation will be under indications, contraindications, anatomy, preparation, steps, aftercare, complications, and common pitfalls. So indication for endotracheal intubation is basically failure of oxygenation or ventilation. So it can be seen as if partial pressure of arterial pressure of oxygen is less than 60 millimeters of mercury on 60% FiO2, or if the arterial partial pressure of carbon dioxide is more than 50 millimeters of mercury, or if there is any inability to maintain or protect the airway, or if there is any severe systemic conditions like hypotensive shock, or in case of cardiopulmonary resuscitation, or we are giving anesthesia to the patient, or we need to perform some procedures which require sedation, or we are giving neuromuscular, or we are facing a patient of neuromuscular disorders. For contraindications, there are no absolute contraindications, but relative contraindication is anticipated difficult airway, the patient is difficult to intubate, or we require alternative airway, or we are waiting for the expert team. So there is a basic difference in the anatomy of an adult patient and a pediatric patient. In case of adult patient, the airway is cylindrical in shape, whereas in case of pediatric patient, it is funnel shape. In case of adult patient, the tongue is not large as compared to the pediatric patient. In case of pediatric patient, tongue is very large, which occupies most of the area inside the oral cavity. Epiglottis in adult patient is shorter, whereas in pediatric patient, it is floppier and it is U-shaped. So epiglottis is easily collapsible. In case of adult patient, the narrowest part is basically vocal cord, and in case of pediatric patient, the narrowest part is the cricoid ring. These are the basic differences, and the other one difference that makes intubation in pediatric patient difficult is anterior placement of the airway. So by nature, airway in pediatric patient is more anteriorly placed compared to the adult patient. So before performing the procedure, we need to align the airway of the patient. So we can see in the slide that there is a relatively large head size in infant. Because of this large head size, there is a natural flexion, and this natural flexion is compressing the soft tissues in the neck area. And the tongue is relatively large, and tongue keeps falling back, which leads to the airway obstruction. So we need to align this airway, and for this airway alignment, we have certain endpoints. Like if we see the glabella and the chin plane, they should be in the line parallel to the horizontal surface. So this line should be parallel. And if we see the neck area, it should be wide and open. There should not be any compression. And if we see the external auditory meatus of the patient and the sternal notch of the patient, this again should form a straight line, and this line should be parallel to the ground or parallel to the horizontal surface. So to achieve this position, we can use first we can place the child on the horizontal surface. We can check the endpoints. Then we can place the headrest. Again, we can check the endpoints. And if still those are not achieved, in that case we should place a shoulder roll, and again we should see the endpoints whether our airway is aligned or not. So we have to obtain the sniffing position before attempting for endotracheal intubation. So this is again the slide which is showing what was the difference in the right position and the position in which the child is placed in this slide. So we have to achieve the endpoints. So this is again the sniffing position or the ear to sternal position, ear to sternal notch position. In the slide again, we can see the landmark which we need to obtain before attempting for the laryngoscopy. So in infant, there should be a line which goes through the ear of the patient and anterior part of the shoulder. This line should be straight and it should be parallel to the ground. And to achieve this parallel alignment, we can place a shoulder roll in case of infant. For a small child, we might not need to do anything. We can just place the child on the horizontal surface, giving slight neck extension, and see if this line is parallel to the ground or the endpoints we are hoping for have been achieved or not. In case of older child or in case of adult, placing a headrest will solve the problem and will align the airway. So this is how we can achieve the sniffing position or ear to sternal notch position. So once we have placed the patient in the optimal position, next thing we need to do is we need to keep a picture in our mind that if we are doing a laryngoscopy and we are going inside, what are the structure, anatomical structure we are aiming for. So this is the structure that we are aiming for. This is the airway opening. This is how it looks like. These are the vocal cords, two glistening white structures which are lined by the epiglottis and by the epiglottic folds and arytenoid cartilage. This is the vallecula where we place our tip of the laryngoscope, and this is the glottic opening. So if we see in this picture, this glottic opening is lined by two glistening white structures which are easily identifiable once we have a picture in our mind. And this is the airway. This is the anatomical landmark that we are aiming for. So again, this is the picture which is showing the anatomical landmark. The other important thing that this picture is showing is this. This is the esophageal opening. So this is where we mostly make the mistakes. So if we see the airway opening and the esophageal opening, we can see how the airway opening is different from the esophageal opening. So we should always try to see these vocal cords which lines the glottic opening. That's how we won't miss the esophagus and the glottic opening. This slide again showing the esophagus and the glottic opening. So as the age changes, the shape of the epiglottis changes. In case of newborn, it is inverted U shape. In case of child, it is triangular. And in case of adult, it is semicircular in shape. So this is how it changes. So for intubation and for laryngoscopy, there are certain preparation. So this is basically the checklist, and we can remember the equipments or the drugs equipments required in this checklist by SOAP me. For S, it is the suction apparatus. So suction apparatus can be wall mounted or it can be standalone. Suction pressure should be between 80 to 100 millimeters of mercury. Suction tube should be available and suction catheter should be available in the sizes of 8 to 14. Then we need oxygen. It can be provided by non-rebreather mask or by the nasal cannula or ambu bag with reservoir, or we need oxygen tubing. For the airway, we should have appropriate size endotracheal tube. Then we should have oral and nasal airways, and we should have laryngeal mask airway. Then we should have personal protective equipments, which is very important. For me, it is M is for medications. So we need pre-medications, we need paralytics, we need resuscitation medication just in case if we land up into some complications. These resuscitation medications are epinephrine, atropine, and fluids. And the other equipments that we need is the laryngoscope, appropriate size blade for the laryngoscope, mask, appropriate size ambu bag, stillets, IV lines, syringes, tape, towels, pads for airway alignment, stethoscope, monitors, and tidal carbon dioxide, calorimetric or capnograph. And we should keep the ventilator ready once we have done laryngoscopy and intubation. So in the equipment list, first of all, the laryngoscope. So there are basically two type of laryngoscope. One is the Miller blade, another one is the Macintosh blade. Miller blade, as we can see, it is the straighter and it is thinner compared to the Macintosh blade. Miller blade is useful in case of infant and young children. And when we are doing laryngoscopy using Miller blade, we lift the epiglottis directly. We don't engage the tip of the laryngoscope into the vallecula. Whereas in case of Macintosh, we engage the tip of the laryngoscope into the vallecula and try lifting the epiglottis. So this is the basic difference. And Miller blade provides the better control of tongue compared to the Macintosh blade. And this is the Macintosh blade, which we can see it is curved, it is wider. It can be used in case of older children and adult. So as we have already discussed, place the tip of the laryngoscope into the vallecula and then do the lift. And this blade curves around the tongue and it basically controls the tongue coming into the vision. So these are the different sizes of laryngoscope. Age appropriate sizes are given. For preterm, we can use we should use Miller blade 0.0 to 0. For term neonate, it is 0 to 1. For infant and toddler, it is the Miller blade size 1. In case of preschool children and school children, we can use Macintosh blade size 2 and 2 to 3. So we need appropriate size of endotracheal tube, and how can we determine the size of the endotracheal tube is by this formula. If we are using an uncurved endotracheal tube, then we can calculate by age in year by 4 plus 4. And if it is a curved endotracheal tube, then it is age in year by 4 plus 3. And we should always keep a size above and a size below from the size that we have calculated, just in case we need it. After the appropriate size endotracheal tube, we know how deep we should insert the endotracheal tube. For this, again, we can remember by age in year by 2 plus 12, or we can just roughly calculate the internal diameter of endotracheal tube with 3. And the cuff pressure in the balloon should be less than 20 centimeters of water. So these are the sizes which are useful in case of pediatric patients. And the size of the endotracheal is defined by the inner diameter of the endotracheal tube, and this inner diameter is always labeled on the package. So there is a inner diameter, then there is a corresponding outer diameter. For uncuffed tube it is different, for cuffed tube it is different. So these are the inner diameter and these are the corresponding outer diameters which are given in case of uncuffed tube and in case of the cuffed tubes. The other equipment that we require is the glidoscope stellate, or standard endotracheal tube stellate, or the elastic bougie. These equipments are very useful just in case we are not able to negotiate the endotracheal tube. So we can use this equipment for the help. Then we need adjoint equipments like ambu bag. There are again age appropriate sizes. For neonate, it is 200 to 300 ml. For infant and young children, it is 450 to 500 ml. For adolescents and older children, it is 1000 to 1500 ml. Now we need appropriate mask size after the appropriate size endotracheal tube. And how do we calculate? We don't need to remember the size of the mask. We can just pick a mask and keep the mask on the airway of the patient, covering the nose of the patient and mouth of the patient. The triangular area of the mask should be on the bridge of the nose, and the circular area of the mask should be on the chin of the patient. Then we should see that the mask should not be small enough, not covering this nose and mouth of the patient, and it should not be large as it is covering the eye of the patient. So this is how we can choose the appropriate size of the mask. So this is the appropriate size of the mask, and these are the sizes which are not appropriate. This is very large, covering the eyes. This is very small, not covering the area properly. So this is how we can calculate size of the mask. And then then holding the mask. How do we hold the mask? So we need to learn this technique because it is very useful. So we can use E and C technique for holding the mask. So this is the C of the technique. This is the thumb and this is the index finger. By this C, we just press the mask on the airway of the patient. And with this E, we keep these fingers on the bony prominences of the chin, and we try lift the neck of the patient, giving the upward and outward movement, which is called jaw thrust. So this jaw thrust helps in opening and aligning the airway of the patient. So this is the E and C hold which we can use to hold the mask. And then there is a two-hand technique, and this is the two-hand technique which is described here. With the thumb, we are pressing the mask on the airway of the patient, and with the fingers, we are trying to lift the chin of the patient in the outward and in the upward direction, which is called jaw thrust that we have already discussed. So this is the jaw thrust that we are giving, putting our index fingers on the angle of the mandible and pulling the mandible slightly forward and or in the upward direction. So this is the two-hand technique, and that was the ENC technique. Then we need the other adjoint equipments required are the suction apparatus. So again, there is a corresponding size. If we are using the endotracheal size, then there is a corresponding size which is given in French for the suction catheter. So these are the sizes which are given. And again, the suction pressure should be kept between 80 to 120 millimeters of mercury. The other adjoint equipment that we require is the oropharyngeal airway. Again, this is called the Goodell airway, which is available in the sizes of 00 to 4, and it is color coded as well. So this is 40 to 20 centimeter of length, and for choosing the appropriate size of the Goodell airway, keep the airway proximal part on the midpoint of the incisor and the distal part at the angle of the mandible, and we see where it lands, where it is corresponding to these areas or not, keeping the curvature in the upward direction. So this is how the appropriate size of oropharyngeal airway can be calculated. Then other adjoint equipment that are required is the tapes for securing endotracheal tube and for monitoring pulse oximetry and capnograph of the patient. Since we are discussing the problems of COVID. So in this pandemic scenario, the first and foremost thing which is important is the personal protective equipments. So before checking the equipments for the procedure, we should always check the personal protective equipments. Personal protective equipments should be there. Then for pre-medications, we use tranquilizers, opioids, non-opioid analgesics, dissociative agents, or anticholinergic agents, antacids, or H2 blockers. So if we are using midazolam or if we are using a ketamine, so we can use midazolam by IV and IM route. The doses are different and the time of onset depends upon the route that we are using. For ketamine, again, we can use the IV or the IM route. Again, the time of onset depends upon the route of drug. So these are the agents that we can use, midazolam and ketamine. The drugs for resuscitation that we require is the epinephrine loaded syringe, which should be ready in the dilution of 1:10,000, and the dose is 0.01 mg per kg IV. Or if we are facing a bradycardia, then we might need atropine in the dose of 0.02 mg per kg. In case of IV fluids, we can use normal saline. In children, we might need calcium gluconate or hydrocortisone. Then for COVID patient or for any full stomach patient or any trauma patient, we need to do rapid sequence intubation. So these are, apart from these preparations, the other important thing, which is very important, is the neuromuscular agent, whether we are using neuromuscular agent or not for the rapid sequence intubation of the patient. And if we are using neuromuscular agent of the patient, the neuromuscular agent for relaxation, then we should always do check ventilation of the patient. So place the mask, take the ambu bag, and first of all check ventilate the patient just in case of any anticipated difficulty airway, and then only we should use the neuromuscular agent to the we should give the neuromuscular agent to the patient.
Hello, Dr. Kavita.
Hanji ma'am.
Your voice is
breaking.
Very volume is very low.
Now it is fine, ma'am. Hello.
Now it is fine.
Oh, okay, ma'am. I'll try keep it like this. For rapid sequence intubation, we need drugs, and these drugs are induction agents, depolarizing agents, non-depolarizing agents. For induction agents, we can use the etomidate, propofol, ketamine, fentanyl, or midazolam. The doses are given, and the time of onset is different for different induction agent, and the duration of action is also different. So there are certain contraindications, or not contraindications actually, but there are certain conditions in which we should keep in mind that whether this drug should be used or not. And for depolarizing paralytic agents, we can use succinylcholine. And for non-depolarizing paralytic agents, we can use rocuronium or vecuronium. For pre-oxygenation, we should use 100% oxygen for 3 to 5 minutes. This pre-oxygenation basically increases the safe apnea time of the patient. And in case of spontaneously breathing patient, we can use non-rebreather mask or the nasal cannula. But if the patient is in apnea or gasping or patient is not breathing, in that case, we should use bag and mask ventilation. So step 1 is the proper position, give the gentle neck extension. And this is generally what we need just to open the airway and align the airway. And this is what we do before attempting for laryngoscopy. So first of all, the proper position. Then second step is holding the laryngoscope. So try holding the laryngoscope into the non-dominant hand. So with the dominant hand, we can do airway manipulation. We can open the airway of the patient, or we can nicely negotiate the tube inside the inside the glottic opening of the patient. So this is the hold which we can use while doing the laryngoscopy. First is the classic technique, and there is a better way to hold the laryngoscope, which we mostly use in case of pediatric patient, which is grasping the handle near the blade as shown in this finger with thumb and the fingers. So this technique provides better control of the airway in case of pediatric patients. So in pediatric patients, we can use this technique. or if we have a older patient or if we have a adult patient, then this is the technique that we can use. So these are the two techniques which are described for holding the laryngoscope of the laryngoscope. Then step 3 is we need to open the mouth of the patient. So we can use the scissoring technique to open the mouth of the patient. So with the thumb we can push the lower lip of the patient, and with the finger we can open the airway. And then there is an insertion of the laryngoscope. So when we are inserting the laryngoscope inside the mouth of the patient, never go through the middle. Always go from the angle of the mouth. So this is the angle of the mouth that we are using. So this is how we should insert the blade of the laryngoscope, and we should not go through the middle part of the mouth. Sorry. This is showing the insertion of the laryngoscope. So when we are inserting the blade of the laryngoscope, we should always go slowly, and we should always keep visualizing the structures, and we should not do the procedure in hasty manner. So this is the incorrect blade insertion which is shown in this finger. So we should always use the angle that we have already discussed, and we should not go through middle part of the mouth of the patient. Then when we are doing the laryngoscope, always keep identifying laryngoscopy, always keep identifying the structures that we need to identify. And this is the ultimate structure where that we need to identify. This is the epiglottis. So advance the blade. For the cricoid pressure, if the patient is full stomach, or if we are dealing with a pregnant patient, then these are the indication for using the cricoid pressure. And initially we used to use this technique, but cricoid pressure might distort the anatomy of the patient. So it is better not to use if we are not well versed with the procedure, because it will distort the anatomy and it will make identifying the airway structures difficult for us. So using a cricoid pressure depends upon the conditions. So if we are dealing with the adult patient, then directly lift the epiglottis, engaging the blade into this area. And if we are dealing with pediatric patients, then engage the tip of the laryngoscope into this area, which is the vallecula. So engage the blade into the vallecula and then lift the epiglottis. So once we have lifted the epiglottis, these are the structures. This is the glottic opening that we will be able to identify. And through this glottic opening, we will negotiate the tube, and this is how we will achieve our endotracheal intubation. So once we have placed the tube, then we need to check whether the tube is at the correct position or not. For this, clinically, we can assess by bilateral chest rise with each ventilation. We can auscultate, and there should be equal air entry bilaterally, and auscultate over the abdomen area. There should not be any breath sounds which are audible at the abdomen area. Then on the monitor, we should see adequate oxygenation. The SpO2 of the patient should be more than 90%. Or in the Kapnock graph, there is a proper waveform which should be shown, which should be visible on the monitor, or there is a color change which will show the correct position. Or if we use the chest X-ray, then our tube position, our tip of the tube should be 3 centimeter above the level of carina. This is the waveform of the capnograph, and this is the color change. And this is the waveform. This waveform should be visible on the monitor, which shows the proper endotracheal intubation with the correct placement. And this is the SpO2 of the patient. So we should achieve for SpO2 more than 92%. And this is the chest X-ray, which is shown. The tip of the tube should be more than 3 centimeter above the carina. And if we are not, for some reasons, if we are not able to use the endotracheal intubation, or if we are not successful with the endotracheal intubation, then we can use the laryngeal mask airway to secure the airway of the patient. So this is the laryngeal mask airway. Before using the laryngeal mask airway, always deflate the cup of the laryngeal mask airway. So it will lead to deflation of this area. So always lubricate this area, then hold the laryngeal mask airway into the pen holding fashion. And after holding, insert the laryngeal mask airway along the hard palate and roof of the mouth of the patient. And once we have inserted the laryngeal mask airway, once we have further advanced the laryngeal mask airway, we will again inflate the cuff of the LMA, and there will be slight outward movement of the LMA, which again indicates toward the proper positioning of the LMA. So this is how we can do LMA insertion in case we are not able to achieve the endotracheal intubation. And once, whether we have used endotracheal intubation or we have used the laryngeal mask airway, what we need to do is securing our airway equipment. So for this, we need tapes. So these are the tapes. We have taken a tape and we have slit it between. So this is how we can use the endotracheal tube. We can fix the tape, and then we can take the other end, securing it around the endotracheal tube, and again pasting on the upper lip and the lower lip of the patient. So these are the techniques which are shown for securing the endotracheal tube with the dynaplast. Again, this is the technique which is shown for the small patient, pediatric patient. Then after the procedures, there are certain complications that we might face, and these complications can be hypoxemia, bradycardia, or hypotension or hypertension. Patient may land up into laryngospasm, bronchospasm, or we can cause trauma to the mouth of the patient, or larynx, or vocal cords, or we can do esophageal intubation, or there might be perforation, or there can be tracheal perforation, or there can be emesis which can lead to aspiration and then cardiac arrest of the patient. So if we, once we are done laryngoscopy and intubation and we are facing acute deterioration post intubation, then we should rule out four things. One is the displacement or misplacement of the endotracheal tube. Other is obstruction because of the secretion or because of the blood, or there can be pneumothorax, or there can be equipment failure like ventilator failure. So we should always rule out these conditions if there is acute deterioration. Then the common pitfalls that we face while doing the procedure is because of certain flaws that we have while doing the procedures. Like when we are doing the laryngoscopy, we are doing rocking movement of the laryngoscope, or if there is inability to visualize the glottic opening because we have gone beyond the vocal cord opening because blade is inserted too deep, or there is a improper positioning, we have not achieved the endpoints of the airway, or we can cause right mainstream endotracheal intubation, and right side is only being ventilated, left side is not being ventilated. Or if we are not well versed with the procedure, then we can take multiple attempts. So we should try keeping our attempts less than 3 within 20 to 30 seconds. And to avoid any kind of failures, we should always have a checklist, equipment checklist. And before attending for the procedures, we should always check the equipment according to this list. Then in case of COVID-19 pandemic, the important thing is adequate personal protective equipment. First of all, protect yourself and then go for any procedure. And in case of COVID-19, experienced personnel should do the procedure. And we should always avoid the awake intubation to decrease the aerosol generation. And once we have done the endotracheal intubation, inflate the cup of the endotracheal tube, and then only do the bag and mask ventilation, not before that. And we should not use the open catheters. We should use inline suction catheters in case of COVID-19 patients. So these are the innovations which really help in COVID-19 scenario also and otherwise also. So these are the viral filters, and this is the video laryngoscope. Video laryngoscope provides a certain distance from the mouth of the patient to the person who is doing the endotracheal intubation. And then there is a screen which avoids the failure, because in this screen we can see the structures, we can easily identify the structures, and we can negotiate our endotracheal tube. So these are the innovations. The take-home message for our presentation would be pediatric intervention is an important skill in the management of critically ill children. So knowledge of the relevant anatomy is very important, and we should have appropriate equipments which should be kept ready at all times in pediatric ICUs, crash cart. And medications are very important. So we should know about the type and the dosing of the medication. Uh, there should be stepwise insertion and should be performed for optimal success. Post-intubation care is essential part of intubation process, and complication should be anticipated early and treated early. So this is my presentation, and these are my references. Hello? Hello? Hello?
Yes, ma'am, you're audible.
Okay. So any questions? Any questions? No questions? So should we move to next presentation? So for the next presentation, I would like to invite Dr. Yashwant Rao. And sir will be talking about initial settings and how to titrate. So sir, are you there?
Dr. Kavita Yashwant is just joining. Just wait for 1 minute.
Okay, ma'am. So ma'am, so should I rest my presentation then? Good afternoon, sir. For the next presentation, sir is here. Sir will be talking about how to titrate the ventilator settings. So welcome, sir.
Thank you, Dr. Kavita.
Thank you, sir.
My screen is visible? Hello?
Not yet, sir.
Just a minute. बाकी
सर विजिबल है, बस स्लाइड्स लगा दीजिए सर.
हाँ हाँ कर रहा हूँ. बाकी फुल स्क्रीन करो. फुल स्क्रीन. का सामान है, इसको कैसे लाते हैं? स्क्रीन कैसे आएगा? यशु लॉन्ग
सर आपका प्रेजेंटेशन ये नीचे है दिख रहा है शायद, इसको आपने अभी लगाया था सर, इट वाज विजिबल। हाँ सर, अब विजिबल है। इसको आप थोड़ा मतलब फुल स्क्रीन भी कर सकते हैं, बट ऐसे ही आ रहा है ये। पीडीएफ होगा तो मे बी फुल स्क्रीन ना हो, बट या इट्स विजिबल। यू कैन स्टार्ट सर। सर प्लीज अनम्यूट योरसेल्फ, अनम्यूट कर लीजिए।
Yeah, now it's okay, ma'am.
Yes sir, now you are audible.
I'm really sorry. Actually, I was busy with the meeting and I was planning for 3 p.m. But somehow I can manage. Okay, thank you. Good afternoon, everyone. Now we are going to start how to start the mechanical ventilation, and I think intubation already has been covered, and what should be the initial setting, and based on the clinical parameter as well as the investigation, how to titrate the ventilator setting so that the patient can be extubated. Our main aim of intubation and ventilation is early and safe extubation. So we are going to start with a 10-year-old male OB child. He is having fever for 5 days and myalgia for 5 days. So during COVID time, any fever, myalgia should be taken as COVID until unless it is RT-PCR positive. This child was positive. He was having breathing difficulty and cough since 3 days. Started on oxygen at home as usual. Second wave में हर कोई घर पे ऑक्सीजन लगा लिया था, and patient developed progressive worsening and admitted to the hospital where oxygen requirement has been increased, so that patient was put on NIV, non-invasive ventilation. Oxygen requirement increased to 80% and support was 12/8. So what is the vital? With this much of support, 80% FiO2 and 12/8 का pressure, मतलब PIP is 12 and 8 is peak. Normally बच्चों में हम 6-7 के आसपास रखते हैं, but 8 से हमने start किया. With this higher setting, patient was sleepy. क्योंकि कोरोना जो बीमारी है, कोरोना usually affect the lung, causing ARDS in the pediatric patient or adult patient. So basically, why child is sleepy? So we can think due to CO2 retention, because gas exchange problem is quite high. So due to CO2 retention, child was sleepy because of CO2 narcosis. Appears tired. Why tired? Because child is having hypoxemia, and that's why FiO2 was increasing, support BiPAP started. So he become tired because of higher respiratory rate. Heart rate was 135. In this child, 10 साल का बच्चा है, I expect around 100. So tachycardia is there. Respiratory rate is 50. So tachypnea is also there. So this child is having tachypnea, tachycardia, tired, sleepy, shallow chest movement, bilateral basal crepitations with 100% FiO2 support and 12/8 BiPAP support. Still, child was not maintaining the saturation. It was 89 to 90%. And whenever child removes the mask to drink some water, immediately child's deteriorate and saturation falls to 80%. फ्रेंड्स, सिर्फ इतना पैरामीटर हमारा बता रहा है कि ये बच्चा बहुत ही ज्यादा गड़बड़ है, क्योंकि हटाते ही तुरंत 80 के नीचे आ जा रहा है. इट मीन्स कि चाइल्ड लंग्स आर वेरी बैड कंडीशन एंड child require further more support like invasive ventilation, and child was not able to eat anything since 24 hours, which is again an indication. अगर आप PSBI का साइन पढ़ें WHO वाले का, तो if child is not able to food, this is very severe and dangerous sign. Now Kavita ma'am already had intubated this child, and after intubation this child was referred to my side, and we will start with the ventilatory setting. So first part is ventilatory mode, ventilator mode. Among the ventilator mode, you all know every ventilator have basic three modes are there. One is CMB mode, second is ACMB mode, and third is SIMB mode. CMB mode is कि अगर रेस्पिरेटरी रेट 15 है और हमने अगर सेट किया है 15, तो हर 4 सेकंड पे एक साइकिल आएगी, एवरी 4 सेकंड पे एक साइकिल आएगी. तो CMB मोड में क्या है कि अगर हमने 15 सेट किया तो पेशेंट चाहे इंस्पायर करे चाहे एक्सपायर करे, वेंटिलेटर अपना ब्रेथ देगा, मैंडेटरी ब्रेथ देगा. तो देयर विल बी फाइटिंग बिटवीन द पेशेंट्स breath and ventilator breath, pneumothorax and lots of problem may develop. So CMB mode nowadays we are not using, hope you people also not using. Second is ACMB mode. In ACMB mode, what is the difference between ACMB and SIMB? In ACMB mode, each and every breath will be supported. So problem will be hyperventilation and CO2 was out. In SIMB mode, only set breath will be supported. Suppose अगर SIMB frequency हमने 15 सेट करी है, तो केवल 15 breath को वेंटिलेटर सपोर्ट करेगा, रेस्ट को नहीं करेगा, तो प्रॉब्लम ऑफ हाइपर वेंटिलेशन विल नॉट बी देयर. तो फ्रेंड्स, here at our place we are using SIMB mode only, SIMB mode. So coming to ventilatory mode, I have already covered. इम्पॉर्टेंट पार्ट क्या है कि दूसरा है लिमिट, कि सपोज हमने SIMB मोड चूज कर लिया. और SIMB मोड 2 settings आर देयर, ईदर वी सेट प्रेशर सपोर्ट, प्रेशर लिमिटेड और वॉल्यूम लिमिटेड. इन प्रेशर लिमिटेड वी यूजुअली कीप द PIP 13, 14, 15, 16, 17, 18, 19, 20, 21 like that, but never beyond usually 26, 25. In volume limited mode, we start with 6 ml per kg and we can increase up to 8 ml per kg. That is, तो अगर हमने फ्रेंड्स हमने वेंटिलेटर को ऑन किया, हमने चूज किया मोड में हमने चूज किया SIMB, फिर हम चूज करते हैं कि हम प्रेशर पे लें या वॉल्यूम पे लें. नियोनेट में हम यूजुअली प्रेशर पे लेते हैं और नियोनेट के बाद हम यूजुअली वॉल्यूम पे लेते हैं. बट ऐसा नहीं कि बड़े बच्चों में हम प्रेशर पे नहीं ले सकते हैं, हम प्रेशर पे भी ले सकते हैं. इंपॉर्टेंट पार्ट क्या है कि अगर प्रेशर लिमिट है, मतलब हमने 18 सेट किया, तो 18 प्रेशर, अगर पेशेंट्स का लंग्स काफी खराब है तो उतना वॉल्यूम दिए बगैर ही 18 का प्रेशर लिमिट हो जाएगा. मतलब आफ्टर अचीविंग द 18 प्रेशर, patient will not going to deliver any more volume to the lung. तो हो सकता है कि जो 6 ml per kg का हमारा टारगेट है वो ना डिलीवर हो पाए. तो इन प्रेशर लिमिटेड मोड वी ऑलवेज सी द वॉल्यूम, कि हाउ मच वॉल्यूम इज बीइंग डिलीवर्ड टू द पेशेंट. एंड इन वॉल्यूम लिमिटेड मोड वी ऑलवेज मॉनिटर द प्रेशर, हाउ मच प्रेशर इज created inside the circuit if desired volume is being given. So here monitoring is very important. In volume mode we monitor the peak pressure and it should not go beyond 30, 32. And in pressure mode, we always monitor volume and it should not go beyond 8 ml per kg or less than 6 ml per kg. So we have covered SIMB मोड. SIMB मोड में हमने प्रेशर और वॉल्यूम पे ले लिया बच्चे को. नेक्स्ट पैरामीटर जो हम सेट करते हैं दैट इज रेस्पिरेटरी रेट. रेस्पिरेटरी रेट हमेशा फिजियोलॉजिकल रेंज में रखना चाहिए. जैसे अगर हम कोई नियोनेटल कोविड हम वेंटिलेट कर रहे हैं तो उसका रेस्पिरेटरी रेट हम 40 से स्टार्ट करेंगे बिकॉज नियोनेटल रेस्पिरेटरी रेट इज 40 to 60. तो वी विल स्टार्ट विद 40. जरूरत पड़ने पे हम और बढ़ा सकते हैं. अप टू 1 year, मतलब tachypnea is more than 50. Up to 1 year, 25 to 30. Likewise, 1 to 5 year, 20 to 25, 5 to 12 year, 15 to 20, and in adolescent or adult, 12 to 50. So basically, with increasing age, physiological respiratory rate is lesser. So we have to keep the ventilatory respiratory rate according to the age of the patient. Or we can use the respiratory rate can be titrated based on the EtCO2 if available in your ventilator. But in COVID time, EtCO2 monitoring was very difficult. At our place, we were not doing that. So now, coming to the tidal volume and inspiratory pressure, which I have already covered, कि it should be 6 ml per kg. हमारा बच्चा 30 kg का है तो 180 ml पे हम सेट कर सकते हैं. या PIP, यहाँ पे PIP हमने कहा था कि 14, 15, 16 से स्टार्ट कर सकते हैं, बट PIP 20 to 22 सेंटीमीटर ऑफ वाटर पे ये सेट कर रहे हैं. वाई? Because on BiPAP with 12/8 support, 80% FiO2 patient was not maintaining. तो expected, मतलब there is no parameter कि इस एज में 16, इसमें 18, इसमें 20. It depends on your clinical judgment कि हमें कहाँ से स्टार्ट करना है. But monitoring is very important. अगर हमने 20 PIP सेट किया है तो वॉल्यूम should be delivered around 180 ml. अगर नहीं होता है, कम होता है तो हम बढ़ाएंगे. Important part is what we want to achieve. I have already covered. Now coming to IE ratio. Friends, आजकल वेंटिलेटर में हमने जहां रेट सेट किया अपने आप IE रेशियो सेट हो जाता है. बट वी कैन सी कि व्हाट इज द IE रेशियो. IE रेशियो शुड बी 1:2 to 3. I governs basically oxygenation and E governs basically CO2 elimination. अब सपोज 1 मिनट का टाइम है. 1 मिनट में हमने जो रेस्पिरेटरी रेट सेट किया नियोनेट में 40 का सेट किया, मतलब 60 सेकेंड बाई 40 दैट इज 1.5. मतलब एक ब्रेथ की साइकिल इज about 1.5 सेकेंड. तो हियर इन नियोनेट आई वुड लाइक टू कीप I 0.4, 0.45 or 0.5 so that कि E will be 1 second. तो in neonate sorry, I will be lesser compared to the adult. Why? अगर बच्चा 10 साल का है, हमने उसका रेस्पिरेटरी रेट 15 सेट किया तो एक साइकिल 4 सेकंड की होगी. तो हमने यहाँ पे I 1 सेकंड का रखा तो E हमारा अपने आप 3 सेकंड का हो जाएगा. तो IE रेशियो विल बी 1:3. तो जितना बड़ा बच्चा होगा, जितना एडोलेसेंट और एडल्ट होगा, उसका TI टाइम थोड़ा ज्यादा रहता है. इंपॉर्टेंट पार्ट है कि IE रेशियो शुड बी 1:2 to 3. Now coming to the FiO2. Friends, FiO2, PIP, respiratory rate, ये सब physiological range में होना चाहिए. Our main target is to decrease the FiO2 below 60 up to 24, 25 so that we can have better extubation. But in this child where 80% FiO2, 12/8 BiPAP support, still child was not maintaining the saturation. So I would like to keep the FiO2 0.8, 0.9 and then gradually taper down when the patient starts developing oxygenation. Main part is try to keep the SpO2 level between 92 to 95. Never try to achieve 100% oxygenation by increasing the FiO2 because hyperoxia is more detrimental to the lung. It will cause HOCl, HOBr and superoxide damage. So try to keep the FiO2 below 60, preferably below 30. PEEP. Basically, in neonate, we will start with the PEEP of 3, 4, 5, 6, but I would like to start with 8 PEEP. And I would like to titrate the PEEP subsequently according to the need of the patient. Suppose on 8 PEEP, still oxygenation is not maintaining. I would like to increase the 8, 9, 10, 11, 12. But in pediatric patient, we never go beyond 12. Basically, what is PEEP? This is very important parameter because what does PEEP do? We put the PEEP by the endotracheal tube or by nasal tube. So in this child, since child is intubated, we have put the endotracheal tube in the trachea. So what it does, basically our lungs are, lots of balloons are there. Many balloons, 5%, 10%, 15%, 20% balloons has been collapsed because of ARDS and loss of surfactant due to COVID infection or due to pneumonia. So what PEEP do? PEEP, it causes expansion, reopening of the collapsed alveoli, जिसको हम recruitment कहते हैं. It recruits the collapsed alveoli, one, and it gives a support to the chest wall and all of the all of the airways and alveoli, so that PEEP will not allow alveoli to be collapsed at the end of expiration. That is positive end expiratory pressure. Means कि end of expiration पे जब alveoli are going to be collapsed, this PEEP will give pressure over the alveoli so that the alveoli will not getting collapsed. So it helps. And when the collapsed alveoli will be open up, oxygen requirement definitely will be reduced. It helps our lungs to be the better part of the compliance. I will tell compliance, what is compliance in the next PPT, and it will prevent atelectotrauma, that is atelectasis, or at the end of expiration, COVID lungs will have tendency to collapse. So all the time it will be getting collapsed, then expand, collapse, expand, so there will be trauma. But very important part is, I was saying that PEEP in pediatric patient usually try not to go beyond 12 because excess PEEP will be, air will be filled inside the lungs. It will compress the heart. So it will decrease the venous return from superior vena cava and inferior vena cava. Stroke volume will be decreased. So it can lead to hypotension, and of course, PEEP can cause barotrauma. Second is, friends, trigger sensitivity. Trigger are basically two types. One is flow trigger and is pressure trigger. Every ventilator, but nowadays ventilators are more and more ventilators are coming having flow trigger. What is trigger? Trigger means कि suppose हमने एक ventilator में setting हमने रखी 20 की, तो when the patient will start taking the breath like that, a negative pressure will be created inside the circuit and it will be sensed by the ventilator, and ventilator will support that breath. This is pressure trigger. Same is with flow trigger. When there will be negative flow in the circuit, ventilator will sense the flow and it will deliver the breath or support the breath of the patient. So this is the basically trigger, and very important part, flow triggers will be set, should be set between 2 to 4. Don't try to touch much about the trigger. कब हमें टच करना है कि जैसे कुछ बच्चे होते हैं जो बहुत ज्यादा गड़बड़ होते हैं, हमने फ्रीक्वेंसी सेट करी, जैसे यही बच्चा है 10 साल का है, आई हैव सेट द फ्रीक्वेंसी ऑफ 15 and total calculated respiratory rate is 60, means कि he is taking 45 breath more. And the CO2 was out is there, but oxygenation is not up to date. What I will do? Either I will try to sedate the child fully, or I will increase the flow. तो बच्चा क्या जो अपना स्पॉन्टेनियस रेस्पिरेशन है, अगर वो 4-5 हमने सेट कर दिया, तो जो फ्लो 5 का प्रेशर दे पाएगा, 5 का फ्लो दे पाएगा, ब्रेथ उसी को वेंटी सपोर्ट करेगा, रेस्ट को सपोर्ट नहीं करेगा। तो ट्रिगर बेसिकली जिनको बहुत अच्छा आइडिया है, दे शुड try to touch the trigger, otherwise it should not be touched. With adequate sedation it is being managed. Rise time means कि suppose this child having, हमने 15 की फ्रीक्वेंसी रखी, 1 सेकंड का इंस्पिरेशन एंड 3 सेकंड का एक्सपिरेशन, तो 1 सेकंड के 0.1 मतलब 0.05 to 1 सेकंड में सारा का सारा ब्रेथ दे दिया। तो इसको भी don't try to touch the rise time and trigger sensitivity. Patient will be okay and it is not going to help much more, but if you are very much aware about all these settings, you can do that. Yes, so we have put this patient on SIMB mode and pressure limit, pressure control. We have keep the PIP 22, PEEP up 8 centimeter of water. We have set the respiratory rate 18, IE ratio 1:2, FiO 2.8, and trigger was 0. Sedation was started, midazolam and fentanyl. What do we monitor? हमने ventilation start कर दिया, तो हम क्या monitor करेंगे? Monitoring is very, very important. Why we have intubated this child? We have intubated this child because child was not maintaining oxygen saturation. 1. Child was sleepy, child was tired, child was having tachycardia, child was having tachycardia and tachypnea. एंड हमने सेडेशन स्टार्ट किया है, वेंटिलेटर पे डाला है, तो बीपी में फॉल। तो जिस कारण से हमने बच्चे को इंट्यूबेट किया है, वेंटिलेट किया है, हमें उसी को मॉनिटर करना है। तो फ्रेंड्स, कोविड टाइम इट्स वेरी इजी टू से, यूजली एसजीपीजीआई वाले बार बार बोलते थे आर्टेरिया ब्लस गैस करिए, ये करिए। नो, clinical parameter is much more important in pediatric patient. If childs become active, letharginess has gone, become active, it means ki our ventilation is okay. Heart rate was 135, it gradually goes down to 100, around 100, it means ki our ventilation is okay. Respiratory rate was 50, हमने 15 सेट किया, 15 पे बच्चा ज्यादा 20 तक 5 और एक्स्ट्रा ब्रेथ ले रहा है, it's okay. BP is normal, it's okay. Chest rise is okay, SpO2 is okay. This is the parameter which we monitor in this patient. और चूंकि हमने प्रेशर लिमिट पे रखा है, तो we will monitor the tidal volume and it should be around 180 ml, क्योंकि 30 kg का बच्चा है, तो 30 into 6 180 ml के आसपास होना चाहिए, both inspiratory and expiratory volume. We can see the waveform. ABG is not needed all the time. Only ABG is needed when we are suspecting that some metabolic components are also there. Now, how to optimize the ventilator? तो हमने वेंटिलेटर को सेट किया था कि हमारे सारे वाइटल सही हो जाए। अगर नहीं इम्प्रूव कर रहा है, इट मीन्स कि पेशेंट इज सेटिंग्स आर नॉट ओके। हमें या तो सेटिंग बढ़ानी पड़ेगी, या हमें पेशेंट का सेडेशन अंडर सेडेटेड है, फीवर है, या और भी कोई पैथोलॉजी चल रही है, तो वी हैव टू टेक केयर ऑफ दैट आल्सो। सिक्रीशंस है वेंटिलेटर में, तो वी हैव टू सक आउट द सिक्रीशन एंड ऑलवेज लुक फॉर चेस्ट राइज और किंकिंग ऑफ ट्यूब। सम टाइम आप वेंटिलेटर लगा के आ रहे हो, ट्यूब नीचे लटक रही है, पोछे वाला गया, उसने पोछा मारा, ट्यूब डिस्कनेक्ट हो गई। सम टाइम वेंटिलेटर की सर्किट से उसने पोछा मारा, वो स्विच ऑफ हो गया, बैटरी बैकअप से आधे घंटे चला, फिर बंद हो गया। तो वी हैव टू टेक केयर ऑफ ऑल दीज थिंग्स इफ पेशेंट शोज सर्टेन डिटेरियोरेशन और नॉट मेंटेनिंग द सैचुरेशन। This graph is very important. Please follow my cursor. This is the basically on y-axis you can see this is the volume and on x-axis this is pressure. तो हमारा बच्चा प्रेशर मोड पे है, तो हमने इतना प्रेशर दिया, यहाँ से लेके लगभग 1 सेंटीमीटर का प्रेशर दिया। वॉल्यूम इंक्रीमेंट वाज ऑलमोस्ट इतना नील, बहुत कम, इतना नील आया। But when we increase the pressure from here to here, still volume increment was very less, very less. So friends, and from here to starting point of C loop, C square, you can see कि if we increase the pressure from here to here, this much, it will increase the volume like anything. Itna volume rise ho gaya. This is known as the compliant part of the lung. It lies between lower insufflation point and this is known as upper insufflation point. So we should always try to keep the PEEP here. We should keep the PEEP here. If you set lots of monitoring loops and curve and everything are there, if you set the display of volume and pressure loop, you can see that. Nowadays, newer ventilators are coming and they are showing if you say, they will tell ki what should be the PEEP, what should be the PIP, monitoring the condition of the lung. And BPL ventilator, a very high quality ventilator, and they can tell ki what. So, but by this loop, we can also judge when the you can see the pressure from where minimum rise in pressure cause more increase in the volume. This is the starting point, and our PEEP should be here. You can see from here to here, if we increase the pressure beyond this point, volume increment is almost negligible because curve becomes flat, and this is the beaking effect. Beaking effect. If we increase the pressure from here, suppose अगर हमारा यही बच्चा है जिसमें हमने ये 24 पे सेट किया है, 24 प्रेशर है, 24 से हमने 28 किया, कोई वॉल्यूम इंक्रीमेंट नहीं है, बट डैमेज ज्यादा होगा, वॉल्यूम ट्रॉमा लंग को होगा, तो वी शुड नॉट गो बियॉन्ड दैट. So PIP should be set at upper insufflation point and PEEP should be set at lower insufflation point. Now coming how to optimize the ventilation. Suppose tidal volume is low or minute ventilation is low. Minute ventilation is tidal volume into respiratory rate. So if minute ventilation or tidal volume low, तो what we can do? बेसिकली हमने 22 पे सेट किया था एंड आवर टारगेट वाज टू अचीव अराउंड 180 ml एंड सपोज दिस इज नॉट गोइंग टू 180 ml, बहुत कम आ रहा है, 140, 130, 120, तो दिस इज हाइपोवेंटिलेशन. तो वी कैन इंक्रीज द PIP फ्रॉम 22 to 23, 24, 25 so that we can achieve around 180 ml. Second, before increasing the PIP, always check for any problem in the circuit. All the time when the patient is, and everybody should be knowing, must be knowing, though displacement of tube, O for obstruction, either by tube or by teething, teeth से काट लिया पूरे को, या bronchospasm हो जाए, तो DO obstruction, P for pneumothorax. तो इस तरीके से we should always take care of tubing. Is there any leak or is there any blockage? Compliance will be poor. So it will take time, and don't go, the PIP should not be increased because our mean airway pressure should not go beyond 30. If there is sudden rise in peak pressure, the cause is usually secretion or blockage, or patient had bitten the tube. This can cause sudden rise in the peak pressure. तो इंश्योर कि पेशेंट अगर बाइट कर रहा है तो हम गुडल्स एयरवे लगा दें, किंक है तो उसको हम सही कर दें, सिक्रीशन है तो हम सक कर दें, ब्रांकोस्पाज्म है तो हम नेबुलाइज कर दें. इस तरीके से वी कैन मेक आउट द सॉल्यूशन. Our target blood gas should be, PS should be around 7.3 to 7.5, PaO2 should be 55 to 80, PaCO2 should be 45 to 55. You can see that some permissible hypercapnia is allowed 45 to 55. Some permissible hypoxia is allowed 55 to 80. And this is important because our target is to have SpO2 around 92, 93 to 95, not beyond 95. अब important part आता कि with all this setting, suppose PaO2 is less, means कि less than 50. By this we can increase the PO2. One is increase the PEEP. हम PEEP को बढ़ा सकते हैं. पीप से क्या होगा, और सारी एल्वेलाई रिक्रूट हो जाएंगी, एरिया वेंटिलेशन बढ़ जाएगा, तो हम पीप बढ़ा सकते हैं। 1 सेकेंड, अभी हमने पढ़ाया था आई रेशियो में कि आई डिटरमाइंस ऑक्सीजनेशन, हम आई को बढ़ा सकते हैं। लेकिन अगर हम आई को बढ़ाएंगे, जैसे अभी हमने 1:3 सेट किया, तो हमारा 2:2 हो जाएगा, तो हमारा आई ई रेशियो बराबर हो गया। और इसके बाद अगर हम आई और बढ़ाएंगे तो ये इनवर्स रेशियो वेंटिलेशन होगा, जिससे प्रॉब्लम क्या होगी, there will be problem of CO2 retention. So IE ratio should be changed, but very cautiously. There should not be any CO2 retention. We can increase FiO2 temporarily. Or last part is, fourth part is change in position, that is proning. In neonate, we used to do the proning and we have very good result in neonate. And proning should be for 12 to 16 hours, but one person who is expert in this should be besides the patient, then only you should try proning, otherwise it will be a problem. And sedation is very important, because if patient suddenly move out the head, he may be extubated or tube may be dislodged. So this is very dangerous procedure. If you are doing, you should be there for that particular period of time. तो 4 चीजें हैं जिससे हम ऑक्सीजन बढ़ा सकते हैं। 1 इज पीप बढ़ा दे, 2nd इज आई बढ़ा दे, 3rd इज FiO2 बढ़ा दे, 4th इज हम प्रोन कर दें। इफ PaCO2 इज हाई, तो PaCO2 को वॉश आउट करने का एक ही तरीका है कि हम रेस्पिरेटरी रेट बढ़ा दें। एक दूसरा, जितनी भी ट्यूब की प्रॉब्लम है, ब्रांकोस्पाज्म है तो नेबुलाइज कर दें, सिक्रीशन है तो निकाल दें, एंड अगर कहीं पे ट्यूब डिसलॉज है तो वो हम सही कर दें, एंड एक्सपिरेटरी वॉल्व की प्रॉब्लम है तो वो हम सही कर लें। इंपॉर्टेंट, हम एक्सपिरेटरी टाइम बढ़ाएंगे तो CO2 वॉश आउट होगा, आई बढ़ाएंगे तो ऑक्सीजन बढ़ेगा, ई बढ़ाएंगे तो CO2 वॉश आउट होगा। अलार्म इज वेरी इंपॉर्टेंट, बिकॉज गवर्नमेंट ने कहा है कि 100 बेड का होना चाहिए, 40 वेंटिलेटर है हमारे पास। अगर सारे वेंटिलेटर अलार्म देंगे तो हमें पता ही नहीं चलेगा कि कौन सा क्यों दे रहा है। तो अलार्म सेटिंग इज वेरी वेरी इंपॉर्टेंट। रेट, अब हमने बच्चे का रेट अपना सेट किया था 18, तो हम इसका हाइयर रेट 40 सेट कर दिया, लोअर रेट 10 सेट कर दिया। जब भी 10 और 40 से बियॉन्ड जाएगा रेट, तो तुरंत वेंटिलेटर अलार्म देगी, हमें जाके अलार्म को चेक कर लेना है, बट नेवर म्यूट द अलार्म। इंपॉर्टेंट पार्ट, हमने बच्चे को अपने प्रेशर कंट्रोल मोड पे डाला, SIMB प्रेशर कंट्रोल पे, तो वी हैव टू मॉनिटर द वॉल्यूम। तो वॉल्यूम डिलीवर शुड बी इंपॉर्टेंट, तो 180 शुड बी आवर टारगेट। तो वी विल सेट कि 40 ऊपर 40 नीचे, तो हमने 250 एंड 150 सेट कर दिया या 140 सेट कर दिया। अगर 140 से कम आएगा तो अलार्म बजेगा, तो हमें अपना प्रेशर बढ़ाना है। अगर ये उससे ज्यादा जाता है तो हमें प्रेशर को कम करना है। सपोज पेशेंट स्टार्टेड इम्प्रूविंग, तो बेसिकली हमने जो सेट किया है वो उतना अचीव रहे, उसी के हिसाब से हमें अलार्म को सेट करना पड़ता है। बिकॉज नाउ इट इज वेंटिलेटर आर यूनिवर्सल मोड, सो यूनिवर्सल, तो हमें हर बार अपने लिमिट को सेट करना पड़ेगा। तो दिस इज वेरी इंपॉर्टेंट टू सेट द अलार्म। तो वी हैव started the invasive ventilation in the hypoxemic child who are not improving on the non-invasive ventilation, and we learned ki how to monitor. Very important is the GC and vital monitoring, then ventilator, and last one is the blood gas, and how to optimize the oxygenation and ventilation considering all the monitored parameter. I think this is over. Thank you so much. Any question, please? हेलो, सब लोग सो गए क्या? हेलो,
हाँ डॉक्टर यशवंत,
हमें लगा सब लोग सो गए।
नहीं नहीं, कोई नहीं, सब जगह है।
Thank you, Dr. Yashwant, for such a nice and lucid lecture.
Good evening, sir.
Good evening, sir. Good evening.
No question.
So there is no question for you, Dr. Yashwant.
Thank you, ma'am.
So now we proceed to our last talk of the day, that is weaning and extubation, and this will be taken by Dr. Shiv Pratap Singh from SNMC Agra. So thank you,
Okay.
Yashwant,
Okay, ma'am. Thank you, ma'am.
and welcome, Dr. Shiv.
Okay. Thank you, ma'am. Thank you. Hello. Good afternoon, ma'am. Hello.
Good afternoon.
Good afternoon. Ma'am, please ask the Mamta team to share the screen, please, because I'm in the hospital. I'm not having that my laptop.
Okay. So Mamta team, please share the presentation of Dr. Shiv, extubation and weaning.
Give me a few seconds, sir.
Okay. Hope, ma'am, some of the audience are still are attending the meeting, because I can see only 94 participants are there at the end of the day.
So is the screen visible?
Yes, ma'am. It's
You
visible.
can start, and you can say next. I can will
Okay.
change the slides.
Okay, ma'am. That I will do. So weaning and extubation, because I'm taking the last lecture of the day. I hope I will try to keep you intact with my lecture, so that we can learn how to wean on the ventilator. Because after a very beautiful lecture by Dr. Yashwant, and you might have come to know that how to do the ventilator settings, and how to keep and how to titrate the settings if the patient is on a ventilator. Now the point comes when the patient is on a ventilator and you have gone to the ward and you find that there are patients who is on a ventilator. Now, how would you decide whether the patient has to be continued on the ventilator support or the patient has to be weaned off? Weaned off means that the ventilator support has to be decreased to withdraw that ventilator support. So what are the criteria? What are the different parameters which decide how to wean the patient from the ventilator? Mechanical ventilation is a very key step in the management of critically ill children. As you all know, you have discussed in the last lecture, the ventilation, although life-saving, can have an adverse effect. Adverse effect means if the ventilation support is continued, it is not all. It is said that it is not always beneficial, because it can have so many side effects. The side effect could include even the bleeding. It could have a GI bleeding, could have barotrauma, could have a volute trauma, could have DVT. There are some problems with the ET tube. Patient could have pneumonitis, sinusitis, tracheostomy. There are so many problems that are issued with the ventilation. So this continuation is a very important when the need of the ventilation subsides. This is the main point कि आपको जब patient ventilator पे है, और you have to decide when to wean or the discontinue the ventilator support. The weaning is not a simple process. It is a combination of at least two processes. That is, one, to withdraw the support, and it includes the extubation, the withdraw the ET2 valves. Next. The specific learning objective of the lecture are to understand the goals of weaning from mechanical ventilation, and to understand the physiological concept, the physiology behind it, and how to test for readiness for weaning and extubation. This is very important, and to learn the process. How do we extubate, or how do we wean off the patient from the ventilator? Next. Overview we'll discuss in this subsequent lecture is by the definition, principles, physiological aspects, readiness for weaning and extubation, and the process and algorithm that we follow, and what if there is a failure to wean. The definition, by definition, if we come to know, is the transition from the ventilatory support to a completely spontaneous breathing while gradually withdrawing positive pressure support. Because हम लोग क्या कर रहे हैं, वेंटिलेटर से क्या दे रहे हैं, उसको पॉजिटिव प्रेशर सपोर्ट दे रहे हैं. अब हमें ग्रेजुअली वो सपोर्ट कम करना है, और पेशेंट को हमें अगर पेशेंट स्पॉन्टेनियस ब्रीदिंग पाया जाता है या फिर और कोई किसी और वजह से होगा तो वो नीड उसकी सबसाइड कर जाती है, देन वी हैव टू डिसाइड वी हैव टू wean from the ventilator support. The extubation, the second term is extubation, that is a process of removal of ET tube. क्योंकि अगर हमारे वेंटिलेटर हमारे जो नीड खत्म हो गई है, मान लो वीनिंग हमने कर रहे हैं, उसके बाद हमें क्या करना पड़ेगा, जो ET ट्यूब पड़ी हुई है गले में पेशेंट के, that has to be withdrawn. So that is called process of removal of endotracheal tube, that is extubation. That is the second step involved in weaning the patient. Next, the journey. The most of the time we see that the half the 40% of the time that is required in the weaning, because हमारा का जो हम जो करते हैं वेंटिलेशन, उसमें हमारा जो almost 60% of the time of ventilation and the 40% time is comes in the weaning. So from the start of the ventilation that we titrate, we set the ventilatory setting. Then after, when we come to know that there is the need of this thing, the FiO2 has decreased and the patient is constantly breathing, then we decide we have to go and we have to assess whether we can wean the patient or not. So this time of length of weaning is almost 40% of total duration of ventilation, जो duration of the patient. जैसे अगर हमने 10 घंटे अगर मरीज को वेंटिलेशन पर रखा, फॉर एग्जांपल, तो हमारे को 10 में से 6 घंटे, अगर पूरा 10 घंटे, तो उसमें से हमारे 4-5 घंटे हमारे वीनिंग प्रोसेस में चले जाएंगे, जबकि जो वेंटिलेशन जो है दैट हैज, जो वीनिंग प्रोसेस है दैट हैज टू बी वेरी स्लो. तो वीनिंग प्रोसेस है वेरी स्लो एंड ग्रेजुअल प्रोसेस. वी कैन नॉट अब्रप्टली स्टॉप द वेंटिलेटर, कि हमने वेंटिलेटर बंद कर दिया, ऐसा नहीं कर सकते. दैट हैज टू बी डिसाइडेड meticulously based on the physiological concept and the need of the patient. That is very important. So next, on an average, the weaning phase accounts for approximately 40% of total duration of the mechanical ventilation in children. Next, acute phase, that is there is a जो मैकेनिकल वेंटिलेशन जर्नी है उसमें 3 फेजेस होते हैं हमारे. एक है एक्यूट फेज, दूसरा मेंटेनेंस फेज, तीसरा हमारा वीनिंग फेज है. जैसे मैंने आपको बताया कि जो हमारे जो प्राइमरी लंग रिक्रूटमेंट है, जिसमें कि हम हमारे जो एलुलाई हैं उनको हम रिक्रूट कर रहे हैं टू मीट द नीड whatever the physiology is. So the second step is the second phase is the maintenance phase, कि जब हमने वेंटिलेटर पेशेंट को वेंटिलेटर पे लगा दिया है, पेशेंट को वेंटिलेटर पे ले लिया है, और हम उसके जो सेटिंग्स हैं उसको हम टाइट्रेट कर रहे हैं, एडुकेट उसको जो प्रेशर्स देना है वो मिल जाए, वॉल्यूम डिलीवर कर रहे हैं वो मिल जाए. तो दैट इज द प्रोसेस ऑफ मेंटेनेंस फेज, सो दैट द पेशेंट जो नीड है वेंटिलेशन की, जिस वजह से हम उसको वेंटिलेट कर रहे थे, तो वो चीज धीरे धीरे अपने आप मेंटेन कर लिया. तो उसकी नीड, अगर पेशेंट की फिजियोलॉजी जो भी पैथोलॉजी है वो धीरे धीरे करेक्ट हो रही है, या उसके जो पैरामीटर्स हैं जो कि ठीक हो रहे हैं, then we come on to the third phase, that is a weaning phase. So when the lung function start improving, then we start doing, that is a process that is called weaning phase. Next, weaning, there is a cause of delayed weaning. Weaning ऐसा नहीं हम एकदम कर दिया. There are some cause of delayed weaning. हम जब करते हैं, they expose the patient to the unnecessary अगर हम delayed weaning करते हैं तो उसके कारण क्या हो सकते हैं. There are, मैंने आपको बताया फर्स्ट स्टार्टिंग में बताया कि there are some complications also that are with the continued ventilation. There are exposed, because delayed weaning can expose the patient to an unnecessary discomfort. This can also increase the risk of complications, I told you, like nosocomial pneumonia also, or there could be airways injuries, there could be trauma also, tracheal stenosis can be also. There is increased use of sedative also, because we have to give sedative, relieve the discomfort of the patient while the ET tube is in, and increase ventilation. The most important, that also increase the cost of the care of the patient, because when the patient is on a ventilator, we have to frequently change the tubes, and if in the patient in the private hospital, the cost goes very much high. So the weaning is a simple process, means it's a very simple process. In 75% in the percentage of this in children in PICU, it will not find much difficulty. अगर आप प्रोटोकॉल बेस करेंगे तो 10 से 15% हो गए. ग्रेजुअल वीनिंग ओवर ए पीरियड टाइम, इट विल टेक 5 to 10% ऑफ टाइम. क्रोनिकली वेंटिलेटर डिपेंडेंट आपका 100 में से एक बच्चा होगा जो कि आप वीन करने में आपको बहुत ज्यादा दिक्कत आएगी. तो ये एक हमारे परसेंटेज ऑफ वीनिंग है जिसे हम करते हैं. सिंपली हम बहुत सारे बच्चों में आराम से वीन कर सकते हैं. 75% बच्चों में हमें दिक्कत कितने आने वाली है, तो लास्ट के 25% में, जो कि जिसमें ग्रेजुअली वीन करना पड़ता है, या फिर हमें प्रोटोकॉल बेस्ड वीनिंग करेंगे, देन ओनली विल गेट बेनिफिट from to the patient. We can give the benefit to the patient. Next, the physiological aspects. There are so many aspects. Like if there is a against which ventilator जो हम ventilator support provide करते हैं, तो एक तो हमारा होता है respiratory load और दूसरा हमारा क्या है respiratory capacity. एक तो हमारा होगा लंग का जो हमारा जो लंग की पैथोफिजियोलॉजी होगी, दूसरा क्या होगा लंग की जो मसल स्ट्रेंथ होगी हमारी बॉडी की. तो जो respiratory load is a load against which the patient breathe. Like if there is a low compliance or there is a high resistance or there is an increased dead space or if there is associated some cardiac problem or there is a chest wall disease. So if there are these factors are there, then the patient has to breathe against these parameters, these loads. So it is difficult. If there are other factor is a respiratory capacity, that is ability to generate the force and sustain it. अगर पेशेंट अनकॉन्शियस है, उसको न्यूरल ड्राइव अच्छी नहीं है, जैसे पेशेंट सांस ही नहीं अपने पास ले पाएगा. दूसरा, अगर किसी वैसे मसल पैरालिसिस हो रही है, डायफ्रागमेटिक मसल पैरालिसिस हो रही है या फिर पेरिफेरल न्यूरोपैथी हो रही है, जैसे कि आप देखते हो कि हमारे जीबीएस वाले पेशेंट में रेस्पिरेटरी प्रॉब्लम निमोनिया बहुत ज्यादा नहीं होगा, लेकिन देयर इज अ मसल पैरालिसिस, तो समटाइम वी हैव टू कीप दोस पेशेंट में वेंटिलेटर सपोर्ट. तो इस तरह की जो प्रॉब्लम होती है, तो जहाँ पे न्यूरल जो हमारे प्रॉब्लम है उसकी वजह से भी वी हैव टू सी कि वो एडुकेट जो रेस्पिरेटरी कैपेसिटी है वो नहीं बिल्डअप हो रही. तो हमारे ये अगेंस्ट दीज लोड द पेशेंट हैज टू डू वेंटिलेशन. Next, the physiological concept is that there is a mechanical ventilation is needed. जिनको चाहिए. Sometimes there is a intolerable load. कि जो हमारा जो लोड है, जैसे मैंने बताया दो तरह, रेस्पिरेटरी कैपेसिटी है और एक रेस्पिरेटरी लोड है. तो अगर किसी भी तरह हमारे कोई लोड है कि मरीज सांस नहीं ले पा रहा है उसकी वजह से, तो वी हैव टू प्रोवाइड देम मैकेनिकल वेंटिलेशन. और अगर जो डिफिकल्ट है कि नहीं इंटॉलरेबल है, अगर वो लोड टॉलरेबल है, the patient can take spontaneous breath. So this is the physiological concept behind putting the patient on ventilator. Recognize, it is very important to recognize when ventilatory assistance is no longer needed and to provide appropriate level of assistance until that happens. इसका मतलब क्या हुआ कि हमें ये assess करना पड़ेगा कि बच्चे को कब बच्चे को डिस्ट्रेस हो रहा है. क्योंकि ना बच्चा करें ज्यादा तेज सांस लेगा तो थक जाएगा, और जिस तरह हम लोग बताते हैं कि रेस्पिरेटरी रेट इज वेरी हाई और lung pathology, the patient having so much of lung damage. So उन conditions में patient is not able to tolerate that load, and we have to give mechanical ventilation or ventilator support to the patient. Next, the phases are pre-weaning, spontaneous breathing trial, and extubation. These are three phases. When we go for this weaning process, the first step is the pre-weaning, and the second is spontaneous breathing trial. Third is extubation. ये क्या है, मतलब ये चीज है जैसे कि हमने डिसाइड किया, the patient is already on ventilator and patient is on, you can understand that patient is on maintenance phase where we are adjusting FiO2 and PEEP. हम उसको एडजस्ट कर रहे हैं और पेशेंट को मेंटेन कर रहे हैं. अब हमने देखा कि पेशेंट को जो पीप है वो भी हम धीरे धीरे कम कर पा रहे हैं, और उसकी रेस्पिरेटरी रेट, जितना रेस्पिरेटरी रेट था जो हम दे रहे थे, जैसे मान लो पेशेंट हमारा SIMV मोड पे है, अगर हमने रेस्पिरेटरी रेट उसको 40 सेट की हुई है पेशेंट की, तो हम कह रहे हैं कि हमने धीरे धीरे हमने देखा कि कितने रेस्पिरेटरी रेट पे पेशेंट और FiO2 हमारे 60-70% आ गया है, और हम देख पा रहे हैं कि पेशेंट इज एबल टू मेंटेन द SpO2, पेशेंट कंफर्टेबल है, हेमोडायनामिकली स्टेबल है. इन दीज कंडीशंस वी हैव टू डिसाइड कि दिस पेशेंट इज इन अ प्री-वेनिंग स्टेज. अगर हमने असेस कर लिया कि हाँ, अगर हम इसको स्पॉन्टेनियस ब्रीदिंग ट्रायल देंगे तो पेशेंट को बहुत ज्यादा नुकसान नहीं पहुंचेगा, तो हम क्या करते हैं, स्पॉन्टेनियस ब्रीदिंग ट्रायल देते हैं. जैसे कि हमने वेंटिलेटर सपोर्ट कम कर दिया और वी कैन गिव कि पेशेंट अपने आप सांस लेगा. हमने क्या किया, जो वेंटिलेटर पे हमने जो रेस्पिरेटरी रेट थी उसको हमने जो 40 सेट किया हुआ था उसको हमने कम कर दी. पहले कम करके देखा धीरे धीरे, फिर हमने उसको बिल्कुल कम करके दे दिया. अब देखा कि पेशेंट स्पॉन्टेनियसली ब्रीथ कर रहा है, उसके साथ ही उसकी FiO2 भी कम हो गई है, और पेशेंट अपना जो स्पॉन्टेनियस रेस्पिरेशन है पेशेंट उसको मेंटेन कर पा रहा है, ठीक से नहीं कर पा रहा है, उसके साथ वो अपना SpO2 मेंटेन कर रहा है कि नहीं कर रहा है, या पेशेंट का उसके पास डिस्ट्रेस तो नहीं बढ़ रहा है. अगर ये सब चीज नहीं हो रही है कि पेशेंट को डिस्ट्रेस नहीं बढ़ रहा है, पेशेंट हेमोडायनामिकली स्टेबल है, पेशेंट को कुछ जो डिस्ट्रेस है जैसे मतलब जो रेस्पिरेशन है वो वर्क नहीं कर रही है, तो हम क्या करते हैं कि हमें लगता है हमारा SBD ट्रायल हमने पेशेंट को दिया है वो सक्सेसफुल, देन वी गो फॉर द थर्ड स्टेप, दैट इज एक्सट्यूबेशन. Next. The most important is when to wean. This is very important to understand कि हमें कब कब पेशेंट को वीन करना है, ये 4 स्टेप बड़े इंपॉर्टेंट हैं। सबसे पहले क्या है, अगर हमने देख लिया कि पेशेंट को हम पेशेंट इज ऑन वेंटिलेटर सपोर्ट एंड वी आर एबल टू मेंटेन, द पेशेंट इज एबल टू मेंटेन एप्रोप्रिएट ऑक्सीजन हो रहा है। दूसरा स्टेप ये है कि पेशेंट इज आल्सो एबल टू मेंटेन द एडिक्वेट वेंटिलेशन। अपार्ट फ्रॉम द थर्ड स्टेप इज दैट देयर इज एब्सेंस ऑफ मेजर ऑर्गन सिस्टम फेलियर। कोई भी बच्चे को कोई एज एमओडीएस नहीं हो रहा है और बच्चे का कोई दूसरा जो सिस्टम है बॉडी का कि वो उसमें कोई बहुत मेजर डैमेज मतलब मेजर डिसफंक्शन नहीं है। अपार्ट फ्रॉम देयर इज इंटैक्ट एयरवे प्रोटेक्टिव मैकेनिज्म। ऐसा ना हो कि हम ट्यूब निकाल लें और बच्चा कोलैप्स कर जाए। तो हमारा जो जो एयरवे प्रोटेक्टिव मैकेनिज्म है वो जरूर इंटैक्ट होना चाहिए। दीज आर द 4 बेसिक पैरामीटर दैट डिसाइड whether we can wean the patient or not. Next. रेडीनेस टू वीन, हमारे जो मैंने आपको बताया 4 स्टेप हैं, उसमें से फर्स्ट स्टेप दैट वाज एप्रोप्रिएट लेवल ऑफ ऑक्सीजनेशन। ये हम कैसे डिसाइड करेंगे, अगर हमने देखा कि हमने जो पार्शियल प्रेशर ऑक्सीजन है वो 60 देखो 40% जो ऑक्सीजन जो FiO2 है, जो 40% FiO2 से कम हम दे रहे हैं और 5 सेंटीमीटर वाटर से पीप उसको कम दे रहे हैं, उसके बावजूद भी मतलब वो कितने सेटिंग पे भी अगर वो PA2 मेंटेन कर रहा है और SQ2 94 to 100% मेंटेन कर रहा है, तो हम देख लेंगे कि पेशेंट इज हैविंग अप्रोप्रिएट लेवल ऑफ ऑक्सीजनेशन। द सेकंड स्टेप इज एडिक्वेट वेंटिलेटरी स्टेटस, दैट इज बच्चे की जो रेस्पिरेटरी रेट है, जो आपने बहुत फर्स्ट सेकंड लेक्चर में पढ़ी होंगी, जब आपको पढ़ाया गया होगा कि नॉर्मल पैरामीटर्स क्या होते हैं रिकॉग्नाइजिंग ऑफ सिक चिल्ड्रन वाले में, तो आपने देखा होगा रेस्पिरेटरी रेट बताई गई हो, तो एज अप्रोप्रिएट रेस्पिरेटरी रेट होना चाहिए उसकी। The second is age appropriate minute ventilation. आपको लास्ट लेक्चर बताया गया मिनट वेंटिलेशन क्या होता है, that is to maintain partial pressure of oxygen. That PaCO2 जो है, जो हमारी कार्बन डाइऑक्साइड जो है ब्लड में लेवल्स है, that should be in the normal range, that should be in the 35 to 45. और जो हमारा जो VT है, that should be tidal volume VD ratio है, VD upon VT वाला, that should be less than 60%. And the important one is the patient should have an intact ventilatory drive. इसका मतलब क्या हुआ कि बच्चे की वेंटिलेटरी ड्राइव लेने की क्षमता होनी चाहिए कि अपने आप सांस को ले सके। एबिलिटी टू कंट्रोल देयर ओन लेवल ऑफ वेंटिलेशन, मतलब उसको सांस लेने की जरूरत पड़े तो अपने आप ले सके। दिस मीन्स दैट चाइल्ड शुड बी न्यूरोलॉजिकली इंटैक्ट एंड देयर शुड बी फंक्शनल रेस्पिरेटरी मसल। दैट इज आल्सो वेरी इंपॉर्टेंट, बिकॉज अगर फंक्शनल रेस्पिरेटरी मसल्स नहीं होंगी या फिर मसल पैरालिसिस होगी किसी डिसीज की वजह से, फॉर एग्जांपल there could be some SMA also, spinal muscular atrophy वाले केसेस हो गए, GBS वाले केस हो गए, उस तरह केस होते हैं जबकि जहाँ पे मसल की स्ट्रेंथ हमारी इतनी अच्छी नहीं होती, तो ऐसे केसेस में भी आपको we have to be very careful and we have to decide this step or this parameter also कि the patient should have a functional respiratory muscle. Next. The third step was the absence of major organ system failure that I told you. There should be, patient should be hemodynamically stable. That means the patient should have a normal cardiovascular function. That there should be no arrhythmias, there should be no fluid overload or myocardial contractility, or should be optimized. Normothermia, the patient should not have a fever. The child should have a normal electrolytes. There should be adequate nutritional status. There should be optimized renal, liver and GI functions. और ABG करा के देख लें, अगर सब कुछ stable है, then we can decide to have be in the patient. The fourth step was the intact airway protective mechanism. इसका मतलब क्या हुआ कि अगर protective mechanism ऐसा ना हो मतलब कि बच्चा खांसी नहीं पा रहा हो अपने पास है ना, तो उसको मतलब सीक्रेशन आ जाए, child could not take out. So there should be intact cuff reflex, intact gag reflex. इसका मतलब क्या हो, बच्चा कॉन्शियस होना चाहिए, उसका GCS should be more than 11. ये हमारे these are the parameters they decide whether we have the child is ready to be weaned off or not. These 4 parameters: oxygenation level, absence of major organ system failure, intact airway और respiratory muscles की जो strength है उसको जो neurological drive है, वो सारी चीजें अगर मौजूद हैं, अगर ठीक है, then only we can decide whether we can wean the patient from this ventilator or not. Next. Spontaneous breathing trial. Just I told you in last slide. हम क्या करते हैं कि हम जो हमारा ये क्या होगा, प्री वीनिंग फेज हो गया, हमने डिसाइड किया है 4 पैरामीटर के बेसिस पे कि अब हम इसको वीनिंग स्टार्ट कर सकते हैं। लेकिन वीनिंग स्टार्ट करने से पहले हमें क्या देना पड़ेगा पेशेंट को, तो हमारे को स्पॉन्टेनियस ब्रीदिंग ट्रायल करनी पड़ेगा। क्या करना, ट्रायल करना पड़ेगा। दैट हम कैसे कर सकते हैं, वी कैन डू बाय, हम जैसे वेंटिलेटर सपोर्ट कम करके या तो हम पीपीस पे ले लें उसको, या फिर हम उसको पूरा सीपैप जो मोड होता है वेंटिलेशन उस पर ले लें, जिसमें कि हम उसको रेस्पिरेटरी रेट नहीं सेट करते, हम सिर्फ उसमें पीप सेट करके 5 सेंटीमीटर पीप सेट कर रख देते हैं। अगर उस पर सीपैप अगर मेंटेन कर रहा है तो फिर अगर तो हम उसको वी कैन असेस, और हमें कितनी देर के लिए करना है, दैट है वी हैव टू गिव द ट्रायल फॉर एटलीस्ट 30 मिनट और 30 to 120 मिनट्स। अगर हमारा एसबीटी ट्रायल सक्सेसफुल रहता है देन ओनली वी कैन गो फॉर फर्दर स्टेप। तो ये हमें डिसाइड करेगा कि हम इस बच्चे को एक्सट्यूबेट, इसके बाद क्या करें, थर्ड स्टेप इज एक्सट्यूबेशन रेडीनेस टेस्ट, कि हम उसको एक्सट्यूबेशन के लिए बच्चा रेडी है कि नहीं है। द थर्ड इज वीनिंग मॉडलिटी, दैट इज इंक्रीज लेंथ ऑफ, अगर वीनिंग हम कैसे कर सकते हैं, एसबीटी ट्रायल दे रहे हैं, और दूसरा पीरियड ऑफ रेस्ट बिटवीन ट्रायल्स एंड एट नाइट। जब हम क्या करते हैं, हम बच्चे को थोड़ा सा रेस्ट देते हैं कि बीच में हमने दिया रेस्ट दे दिया, और हम बीच में फिर उसके बाद फिर दोबारा ट्रायल किया, उसका एसबीटी ट्रायल दिया। अगर वो सक्सेसफुल होता है देन ओनली वी कैन डिसाइड कि द चाइल्ड कैन बी एक्सट्यूबेटेड। नेक्स्ट, द स्पॉन्टेनियस ब्रीदिंग ट्रायल। हमारे पास वैसे ये है कि हम दो तरह के क्राइटेरिया होते हैं, देयर हम कैसे असेस कर पाएंगे हमारा जो ट्रायल है वो सक्सेसफुल हुआ है कि नहीं हुआ है। अगर एक तो ऑब्जेक्टिव क्राइटेरिया है जो कि हम मशीन पे देख सकते हैं या फिर हम देख सकते हैं, जैसे कि हम एग्जामिनेशन में देख सकते हैं, जैसे कि बच्चे को टेकिपनिया हो रहा है कि नहीं हो रहा है, ये दीज आर ऑब्जेक्टिव क्राइटेरिया जो कि हम देख पाएंगे, मशीन को मॉनिटर नोट डाउन कर पाएंगे। और टेकिकार्डिया हो रहा है कि नहीं हो रहा है, हाइपोटेंशन हो रहा है कि नहीं हो रहा है, बच्चे का ब्लड प्रेशर तो फॉल नहीं कर रहा है, और बच्चे का PO2 तो हाइपोक्सीमिया तो नहीं हो रहा है, SPO2 हमारा PO2 तो कम नहीं हो रहा है, एसिडोसिस तो नहीं हो रहा है, PS तो नहीं हमारा बढ़ रहा है, और रिदमिया तो नहीं हो रहा है। अगर हमने देख लिया कि ये सारी चीजें नहीं है देन हाँ, ये ऑब्जेक्टिव क्राइटेरिया। दूसरा सब्जेक्टिव क्राइटेरिया हमारे होते हैं, या डायफोरोसिस है कि नहीं है, एविडेंस ऑफ इंक्रीजिंग रेस्पिरेटरी एफर्ट, मतलब उसे सांस लेने के लिए और एफर्ट तो नहीं करना पड़ रहा है। तीसरा नेजल फ्लोइंग, मैंने बताया एसेसरी मसल ऑफ रेस्पिरेशन तो वर्क नहीं कर रहे हैं, पेशेंट एंक्सियस तो नहीं है, पेशेंट एजिटेटेड तो नहीं है। These are subjective criteria to decide whether the spontaneous breathing trial is successful or not. Next, weaning is successful or failure. हम कब कहते हैं, जब हम सक्सेसफुल वीनिंग कब कहेंगे, when there is absence of ventilatory support for 48 hours following the extubation। अगर हमने किसी पेशेंट को वीन ऑफ कर दिया वेंटिलेटर से और 48 घंटे तक हमें दोबारा इंट्यूबेशन जरूरत पड़ नहीं, उसको एक्सट्यूबेट कर दिया है और दोबारा हमें वेंटिलेटर जरूरत नहीं पड़ती है, then we say that patient the weaning is successful। और दूसरा वीनिंग प्रोसेस इज दैट, मैंने लास्ट स्लाइड में बताया कि डिफिकल्ट, हम 75% में हम आसानी से वीन कर पाएंगे, लेकिन जो डिफिकल्ट है दैट इज 10 से 15% जो केसेस होते हैं हमारे में डिफिकल्ट होता है। डिफिकल्ट पेशेंट्स आर हु फेल इन इनिशियल वीनिंग एंड रिक्वायर अप टू 3 स्पॉन्टेनियस ब्रीदिंग ट्रायल। जो कि डिफिकल्ट कौन से होते हैं, जिनमें कि इनिशियल जो वीन करते हैं वो फेल हो जाता है, जो कि जो ऑब्जेक्टिव क्राइटेरिया और सब्जेक्टिव क्राइटेरिया हमने देखा, असेस किया कि दे आर नॉट एबल टू मीट दैट। मतलब अगर वो हो जाते हैं कि ये है, तो हमारे को क्या होता है, हमें 2-3 बार ट्रायल करना पड़ता है। अगर वो सक्सेसफुल हो जाता है देन वी कैन ऑलवेज अचीव द सक्सेसफुल वीनिंग। और प्रोलॉन्ग पीरियड इज दैट पेशेंट हु फॉल एटलीस्ट 3 वीनिंग अटेम्प्ट्स और रिक्वायर 7 और मोर डेज ऑफ वीनिंग आफ्टर द फर्स्ट एसपीटी। अगर आप ऐसे पेशेंट जो प्रोलॉन्ग वीनिंग हम क्या कहते हैं, जो पेशेंट जिनको कि 3 वीनिंग अटेम्प्ट से ज्यादा चाहिए और 7 दिन से ज्यादा लग जाए वीनिंग आफ्टर द फर्स्ट ब्रीदिंग ट्रायल, तो 1 हफ्ते तक हम कोशिश करते रहे और हम वेंटिलेटर से उसको नहीं हटा पाए, तो हम उसे क्या कहेंगे कि देयर इज ए प्रोलॉन्ग्ड वीनिंग प्रोसेस। ऐसे हमारे 5% केसेस लगभग होते हैं जो कि हमारे प्रोलॉन्ग्ड वीनिंग में, या लेस देन 5%, आप 1% के आसपास बोल सकते हैं, जो कि जिनमें कि हमें आपको प्रोलॉन्ग्ड वीनिंग करनी पड़ती है। नेक्स्ट, वीनिंग प्रोसेस। हम जो बैक स्लाइड प्लीज, 1 स्लाइड बैक। जो वीनिंग प्रोसेस है, 2 तरह के वीनिंग प्रोसेस है, एक रैपिड मॉडर्न मेथड है, दूसरा हमारा स्लो ट्रेडिशनल मेथड है। जिसमें है कि हमारे तो रैपिड मॉडर्न मेथड में हम तो शॉर्ट टर्म के वेंटिलेट करते हैं, लेस देन 3 डेज, और जो हमारे ऐसे कंडीशंस होती हैं जिनमें कि हमारे को जल्दी से बच्चा इंप्रूव कर जाता है, जैसे कि शॉक विदाउट मल्टी ऑर्गन सिस्टम फेलियर है, पोस्ट ऑपरेटिव स्टेबलाइजेशन, जैसे कि कोई बच्चा पीडियाट्रिक सर्जरी हुई है, हमारे यहाँ सिर्फ पीडियाट्रिक PICU में स्टेबलाइजेशन के लिए आया है, ऐसे मरीज जो कि पोस्ट ऑपरेटिव होते हैं। और दूसरे जो कि जैसे बच्चे हम कई बार हम लोग बच्चे को सीजर आ रहे हैं, दौरे पड़ रहे हैं, तो हम उसके लिए हम कई बार बच्चे को इंट्यूबेट करके हम उसे वेंटिलेटर पर रखते हैं, या फिर ब्रोंकोस्पाज्म वाले बच्चे जिनको कि एकदम ब्रोंकोस्पाज्म हो रहा है, SpO2 कम हो रहा है, हम उनको तुरंत इमीडिएट वेंटिलेट करते हैं, नेबुलाइज करते हैं और बच्चे जल्दी इंप्रूव हो जाते हैं। तो ऐसे बच्चे हम उनको क्या कहते हैं, दीज आर द चिल्ड्रन हु रिक्वायर अ शॉर्ट टर्म ऑफ वेंटिलेशन, और हम इनको जल्दी से वीन ऑफ भी कर देते हैं। जो स्लो ट्रेडिशनल मेथड होते हैं जो वीनिंग के, जिसमें कि हमारे को बहुत लंबे समय तक वीनिंग का प्रक्रिया चलती रहती है, हम लोग वीनिंग करते हैं जिसमें कि वेंटिलेशन हमारे को 3 दिन से ज्यादा करना पड़ रहा है। तो जो ऐसे जो डिसीज होते हैं जिसमें कि मल्टी ऑर्गन, जिसमें डिसीज पैथोलॉजी इज स्लो टू रिवर्स, मतलब ऐसी बीमारियां जो कि बहुत जल्दी ठीक नहीं होती है, और जिसमें मल्टी ऑर्गन सिस्टम फेलियर है, जिसमें कि पंप फेलियर हो रहा है, ऐसे जो बीमारियां होती हैं उनमें that require a traditional method means they will require a long time to get themselves weaning, long time for weaning process. Next, basic and of modern and traditional approach. The why there should be traditional approach, why there should be modern approach. The traditional approach is the cautious approach that failed extubation can lead to the increased mortality or morbidity and can increase the cost of the treatment. The modern approach is preferable because 50% of self extubation do not require re-intubation. कई बार क्या होता है, बच्चे अपने आप ही ट्यूब निकाल लेते हैं, आपने देखा होगा एक वार्ड में, तो ऐसे केसेस में हम बहुत बच्चे आराम से 30% पेशेंट नेवर सेटिस्फाई ऑब्जेक्टिव क्राइटेरिया, रेडिनेस क्राइटेरिया कैन स्टिल बी सक्सेसफुली वीन। कई बार क्या होता है, हमने देखा ना कि SBT ट्रायल के ऑब्जेक्टिव क्राइटेरिया है और सब्जेक्टिव क्राइटेरिया है, अगर वो कई केसेस में नहीं भी मिलते हैं तो भी हम उनको वीन ऑफ कर देते हैं मॉडर्न अप्रोच से, तो वो उनमें वी कैन हैव अ सक्सेसफुल वीनिंग आल्सो। नेक्स्ट, Next, the predictors of these are the rapid shallow breathing index है, और CROP index है, और एक leak index है, और apart from that there is a maximal negative inspiratory flow और dead space fraction. None of the parameters are infallible in predicting successful activation. ये जो RSBI है, that is ये जब shallow breathing है, जैसे कि अगर किसी को मसल में स्ट्रेंथ अच्छी नहीं है तो there would be shallow breathing. ऐसे केसेस में आपको there would be difficult prediction, कि ऐसे केस में there will be difficult to predict कि आपको बच्चे को जल्दी वीन ऑफ कर पाओगे कि नहीं कर पाओगे. Like other parameters also have a this kind of value also in predicting the weaning process. Next, predictive indexes are rapid shallow breathing index, that is respiratory rate upon tidal volume. तो ये that has high sensitivity if there is an 8 breath per ml per kg per minute, ये हम ले रहे हैं, तो ये हमारे predictive indexes हैं कि हम उसको predict कर सकते हैं. The compliance जो CROP index है, that is the compliance of respiratory rate, oxygenation of pressure, ये इसका combined index है जो कि decide करता है कि अगर more than 0.15 ml per kg per breath per minute है, तो ये decide करता है कि हम उसको there is a predictive कि हम उसको weaning process में ले सकते हैं या उसका weaning difficult होगी. Next, the steps to follow, the stop or taper sedation, जैसे कि ये बड़ा इंपॉर्टेंट स्टेप है कि the change sedation to a short acting. जैसे हम किसी बच्चे को वेंटिलेशन में रखते हैं, समटाइम वी गिव सेडेशन आल्सो, तो हमारा एक उद्देश्य होता है कि हम उसे जैसे हमने वीनिंग के प्लान किया है तो हम उसका सेडेशन ग्रेजुअली डिक्रीज करते हैं, है ना. और हमारे और भी कंसर्न्स होते हैं दैट वी डिस्कस फर्दर. असेस, द सेकंड स्टेप इज टू असेस द कॉन्शियसनेस एंड मसल पावर. जैसे हमने डिसाइड कर लिया कि पेशेंट को वीन ऑफ करना, तो हम क्या करेंगे, सबसे पहला स्टेप क्या है, स्टॉप और टेपर द सेडेशन. जो सेडेशन हम दे रहे हैं उसको हम धीरे धीरे कम करेंगे, टेपर करेंगे. और दूसरा स्टेप क्या है, असेस द कॉन्शियसनेस लेवल ऑफ द पेशेंट एंड द मसल पावर. मसल पावर मींस कि बच्चे की मसल पावर, रेस्पिरेटरी पावर है कि नहीं है. ये दूसरा. सेकंड इज हैंड ग्रिप. हम कैसे देख सकते हैं, बच्चे की हैंड ग्रिप देख सकते हैं, नेक होल्डिंग है कि नहीं है, किकिंग लेग्स इन एयर, जो छोटे बच्चों में हाथ पैर चला रहा है तो हम देख सकते हैं मसल पावर उसकी ठीक है. थर्ड स्टेप इज वेदर द चाइल्ड एबल टू फॉलो ऑन सीक्रेशंस और नॉट. कि बच्चा अपना, जैसे हम देख पाएंगे बच्चे में गैग रिफ्लेक्स है कि नहीं, कफ रिफ्लेक्स है कि नहीं, तो हम उसको कैसे कर पाते हैं कि वेदर चाइल्ड एबल टू फॉलो हिज ऑन सीक्रेशन. ऐसा ना हो पता लगा कि हमने एक्सक्यूबेट कर दिया और बच्चे के सीक्रेशन की वजह से बच्चे को एस्पिरेट कर गया, तो दिस शुड नॉट बी अ कंडीशन. तो वी हैव टू असेस ऑल दीज थिंग्स. These are the steps to follow while start the weaning of the patient. First step is taper sedation. Second step is assess consciousness. Third step, you have to assess whether the patient can follow his own secretion or not. Next, assess for peritubal leak. तो फोर्थ स्टेप था जो हमारा है कि कहीं से ट्यूब लीक तो नहीं कर रही है. अगर कफ ट्यूब है तो डिफ्लेट द कफ एंड देन लिसन. इफ अनकफ ट्यूब, लिसन फॉर लीक विद इंस्पिरेटरी प्रेशर ऑफ 20 सेंटीमीटर ऑफ वाटर. ये हमें देखना है कि ट्यूब हमारे पहले ट्यूब के आसपास से कहीं से कोई लीकेज तो नहीं हो रहा है. देन द डिक्रीज वेंटिलेटर सपोर्ट एज टॉलरेटेड. दिस इज वेरी इंपॉर्टेंट कि आपको ग्रेजुअली डिक्रीज करना है. कि आपने कि दो अपने जैसे 36 रेस्पिरेटरी रेट है, आपने 2 घटा के 34 कर दी. FiO2 आपका 40 था, आपने FiO2 मान लो 60 था, आपने घटा के उसको 56 कर दिया. तो आपने ग्रेजुअली आपको ये वेंटिलेटरी सपोर्ट आपको देखना है. और ये नहीं कि इमीडिएटली आपने अभी क्या कर दिया. यू हैव टू वेट फॉर एटलीस्ट 2 आवर्स. After that, patient is tolerating that much of patient is able to maintain on that pressures or that FiO2, then we can further decrease these values. These are the gradual process that has to follow while weaning of the patient off the ventilators. Next, the weaning modes. ये आपको modes आपने last lecture में आपने पढ़े हैं बहुत सारे modes ये वेंटिलेटर के बारे में. The ventilator support is reduced as the patient become increasingly able to resume the work of breathing. जो अपना वर्क ऑफ ब्रीथिंग खुद ही करने लग जाता है. तो रेस्पिरेशन, the 3 approaches are we can either go for SIMV, we can have a pressure support ventilation or TP spinning. The preferred is because most of the time we ventilate a patient on SIMV mode, so that is already there when we plan for ventilation. Next, SIMV is the theory of underlying intermittent ventilation. SIMV is the patient respiratory muscles would work during spontaneous breathing intervals and rest during the mandatory breath. मीन्स हम क्या करते हैं, जो SIMV है सिंक्रोनाइज्ड इंटरमीडिएट मैंडेटरी वेंटिलेशन. मीन्स हमने क्या पर्टिकुलर रेस्पिरेटरी रेट सेट कर दी 40. उसमें जब वेंटिलेशन क्या करेगा, जो रेस्पिरेटरी रेट बच्चा नहीं ले पाएगा वो उसको डिलीवर कर देगा या उसको सपोर्ट कर देगा. तो ये एक वेंटिलेशन मोड होता है जो कि बच्चों में बहुत कॉमनली यूज मोड है. तो कॉमन वीनिंग प्रैक्टिस विद SIMV इज टू रिड्यूस द मैंडेटरी रेट प्रोग्रेसिवली. जो मैंने लास्ट स्लाइड बताया कि हम क्या करते हैं, ग्रेजुअली उसको रिड्यूस करते हैं. जैसे कि हमने 1 या 2 ब्रीथ पर मिनट रिड्यूस करी है ना, 8 पेस, एंड विद अ मैचेस दैट पेशेंट इंप्रूवमेंट. हमने उसको धीरे धीरे फिर थोड़ी देर हमने वेट किया. फिर जैसे हमने मान लो कुछ 1-2 घंटे वेट किया, अगर मेंटेन कर रहा है देन वी कैन फर्दर डिक्रीज द दिस रेस्पिरेटरी रेट. The PSV can be added to unload the spontaneous breathe and reduce the patient's work of breathing. तो pressure support ventilation है can be added to unload the spontaneous breathe and reduce the patient work of breathing. हम उसको प्रेशर सपोर्ट भी दे सकते हैं कि जो मसल्स जो हमारे स्पॉन्टेनियस ब्रीथ में जो उसको वर्क ऑफ ब्रीथिंग है वो उसको वो कम कर सकते हैं. नेक्स्ट the PSP is with the PSP the patient controls the rate, timing and depth of each breath. मतलब हमने क्या किया, उसको हमने सिर्फ प्रेशर सपोर्ट दिया है और पेशेंट इज ऑलरेडी टेकिंग द हिज रेस्पिरेटरी रेट. तो हमने क्या किया, हमने की डेप्थ ऑफ ईच ब्रेथ पेशेंट अपना खुद कंट्रोल कर रहा है. PSV इज पेशेंट ट्रिगर्ड, मतलब पेशेंट अपना सांस लेगा और पेशेंट प्रेशर लिमिटेड है और फ्लो साइकिल है. तो पेशेंट इज कंट्रोलिंग ऑल हिज दिस रेस्पिरेशन. The gradual reduction of the level of support as long as the all appropriate spontaneous respiratory rate and tidal volume are maintained, the distance is not evident. When pressure support is reduced to about 5 centimeter of water, मतलब हमारे पीप घटा के हमने 5 पर कर ली है और इतने प्रेशर पे वो मेंटेन कर पा रहा है, इसका मतलब वो पेशेंट ठीक है. However, this level of support is usually sufficient to overcome the work of imposed by the ventilatory system. तो ये हमारा ये प्रेशर को मेंटेन कर लेगा और this level will be sufficient to maintain, और जो वर्क इंपोर्टेड वेंटिलेटर सिस्टम की वजह से होता है वो उसको ओवरकम करता है. नेक्स्ट, TP स्क्रीनिंग. द वेंटिलेटरी मोड इज सेट ऑन स्पॉन्टेनियस, मींस CPAP मोड में हम कर सकते हैं और हम बच्चे को TP स्क्रीनिंग जो हमारी ट्यूब पड़ी हुई हमने उस पर TP से अटैच कर दिया. द एडवांटेज ऑफ यूजिंग वेंटिलेटर इज द अवेलेबिलिटी ऑफ अलार्म्स. की हमारे पास अगर कुछ दिक्कत आती है तो अलार्म तुरंत खुल जाए. जैसे हमने बताया कि अलार्म हमारे सेट होने चाहिए क्योंकि वी हैव सो मच ऑफ अलार्म्स ऑन द वेंटिलेटर, सो वी हैव टू सेट द अलार्म. Basically, this is similar to a small amount of pressure support. Thus, TP trial using a ventilatory mode provide a means of continuous monitoring system, monitoring the patient. Next, the protocol based weaning. हम लोग क्या करते हैं, प्रोटोकॉल है, जैसे कहा ना, एक तो डिफिकल्ट, एक तो सिंपल वीनिंग हो गई, दूसरी हमारी वीनिंग होती थी प्रोटोकॉल बेस्ड वीनिंग. थर्ड इज द डिफिकल्ट वीनिंग. प्रोटोकॉल बेस्ड वीनिंग होती है जो 10 से 15% बच्चों में जरूरत पड़ती है. दैट इज अगर स्पॉन्टेनियस ब्रीथिंग ट्राइड हम डेली दे रहे हैं, वंस द चाइल्ड इज रेडी फॉर वीनिंग, हम उसको जैसे ही बच्चा वीनिंग के लिए तैयार है, हमने असेस कर लिया कि पेशेंट इज प्री वीनिंग स्टेज में है और हमने देखा हम उसको क्या देते हैं, हमने 4 पैरामीटर असेस करके देन वी गिव द स्पॉन्टेनियस ब्रीथिंग ट्रायल टू द पेशेंट. तो हम क्या करते हैं, सेडेशन धीरे धीरे कम कर रहे हैं और दैट शुड बी द सेडेशन विंडो हमारी ये तो मैं कर रहे हैं सजेशन हम करते हैं, लेस बाइस्ड होती है, इट इज नॉट इन्फ्लुएंस्ड बाय द पर्सनल ओपिनियन, और इट हैज अ बेटर ट्रांसपेरेंसी एंड कम्युनिकेशन एंड हैज टू बी फ्लेक्सिबल अकॉर्डिंग टू द चाइल्ड नीड। तो हम क्या करते हैं, ये जरूरी नहीं है कि हम फिक्स कर रहे हैं उसके हिसाब से करें, दैट हैज टू बी डिपेंडेंट ऑन द पेशेंट कंडीशन एंड वी हैव टू डिसाइड अकॉर्डिंगली। नेक्स्ट, ये हमारी वीनिंग एल्गोरिथम है जो कि आप मिलेगी, जो मैकेनिकल वेंटिलेशन है, जैसे मैंने बताया आपको कि अगर हमने अप्रोप्रिएट लेवल ऑफ ऑक्सीजनेशन है, दूसरा स्टेप है वेंटिलेटरी स्टेटस एडिक्वेट है, तीसरा है कोई मेजर ऑर्गन फेलियर नहीं है, चौथा स्टेप हमारा प्रोटेक्टिव मैकेनिज्म उसके इंटैक्ट है। तो हम क्या करते हैं, उसको स्पॉन्टेनियस ब्रीथिंग ट्रायल देते हैं। कितने देर के लिए देते हैं? 30 to 120 मिनट्स। अगर उसमें टेस्ट में पास हो जाता है तो कहते हैं यस, तो पेशेंट इज रेडी फॉर एक्सट्यूबेशन। तो हमारा क्या हुआ, प्री वीनिंग स्टेज हो गई, एसबीटी ट्रायल हो गया और एक्सट्यूबेशन हो गया। इसका मतलब क्या हुआ, हमारा सक्सेसफुल एक्सट्यूबेशन हो गया। अगर हमने एसबीटी दिया और एसबीटी हमारा नो आ गया कि पेशेंट हमारा एसबीटी ट्रायल में सक्सेसफुल नहीं हुआ, तो हम क्या करते हैं, कंटिन्यू द प्रेशर सपोर्ट असिस्ट मोड एंड डिक्रीज द प्रेशर सपोर्ट बाय 2 सेंटीमीटर आफ्टर 12 आवर्स। फिर हमने क्या किया, उसको 24 आवर्स के बाद अगले दिन हमने 24 घंटे बाद हमने उसको फिर स्पॉन्टेनियस ब्रीदिंग ट्रायल हमें देना। अगर इस तरह हम उसको कर सकते हैं। दूसरा हमारा क्या है, इफ देयर इज अ लो लेवल ऑफ सीपैप, अगर 5 सेंटीमीटर से सीपैप और जो मिनिमम सीपैप हम रखते हैं उसमें अगर है प्रेशर फॉर वेंटिलेशन है 5 to 7 सेंटीमीटर वाटर है, तो हम क्या करते हैं, टी पीस ब्रीथिंग पर रखते हैं उसको। तो आप मैंने बताई दिए हैं कि क्या क्राइटेरिया होते हैं, जो ऑब्जेक्टिव और सब्जेक्टिव क्राइटेरिया क्या क्या है, दैट आई टोल्ड यू इन द लास्ट स्लाइड। So this is the algorithm, how do we wean off pre-wean, SBT and extubation. Next. नेक्स्ट स्लाइड। अब बात है रोल ऑफ ट्रैकेस्टमी। जिन मरीजों को बहुत लंबे समय तक प्रोलॉन्ग वेंटिलेशन की जरूरत पड़ती है, तो हमें क्या करना पड़ता है, विल रिक्वायर प्रोलॉन्ग वेंटिलेशन असिस्टेंस, तो ट्रैकेस्टमी शुड बी कंसीडर्ड। ये इंपॉर्टेंट चीज है कि जिन मरीजों को बहुत जरूरत है उनको हम लोग ट्रैकेस्टमी कर देते हैं। ट्रैकेस्टमी शुड बी परफॉर्म्ड आफ्टर एन इनिशियल पीरियड ऑफ स्टेबलाइजेशन ऑन द वेंटिलेटर एंड व्हेन द पेशेंट अपीयर्स लाइकली टू बेनिफिट फ्रॉम द प्रोसीजर, अगर उसको फायदा हुआ तो ये हमारे ट्रैकेस्टमी का रोल है। दीज आर इन केस ऑफ डिफिकल्ट एक्सट्यूबेशन। हमें क्या करना पड़ता है कि कई बार ट्रैकेस्टमी करनी पड़ती है जिन पेशेंट में प्रोलॉन्ग हम उनको एक्सट्यूबेट नहीं कर पा रहे हैं, या फिर किसी भी डिसीज प्रोसेस की वजह से डिसीज प्रोसेस को रिजॉल्व करने लायक नहीं है, रिजॉल्व नहीं हो पा रहा है। नेक्स्ट स्लाइड प्लीज। एक्सट्यूबेशन। अब बात आई कि हमारे को हमने एसबीटी में पास हो गया, अब हमें कैसे एक्सट्यूबेट करना है। रिमूवल ऑफ एंडोट्रेकियल ट्यूब। अब हम रिमूवल ऑफ एंडोट्रेकियल जो स्टेप्स होते हैं एक्सट्यूबेशन के, दैट इज रिमूवल ऑफ एंडोट्रेकियल ट्यूब। प्राइमरी इंडिकेशन फॉर व्हिच द पेशेंट वाज इंट्यूबेटेड है रिजॉल्व्ड इफ द पेशेंट is capable of maintaining stable airway or patient is capable of spontaneous breathing or ventilation and adequate gas exchange। अगर ये 4 क्राइटेरिया हमारे मीट हो रहे हैं तो हम क्या करते हैं कि हम उसको एक्सट्यूबेट करने के लिए तैयार हैं, तो वी कैन डू एक्सट्यूबेशन। नेक्स्ट, द टाइमिंग ऑफ एक्सट्यूबेशन। अगर अर्ली है तो अर्ली एक्सट्यूबेशन करेंगे या डिलेड करेंगे। तो हम अगर अर्ली एक्सट्यूबेट कर देंगे तो हो सकता है हमारे को क्या क्या खतरा हो सकता है, देयर कुड बी अ फेलियर हो सकता है, जो हम कर रहे हैं कि वीनिंग और एक्सट्यूबेशन फेलियर हो सकता है उस तरह का, और री इंट्यूबेशन दोबारा करना पड़ सकता है, और देयर कुड बी इंक्रीज मोर्टेलिटी और दूसरा अगर हम डिलेड एक्सट्यूबेशन करेंगे तो क्या हो सकता है, प्रोलॉन्ग आईसीयू स्टे हो जाएगा, देयर कुड इंक्रीज द कॉस्ट ऑफ ट्रीटमेंट एंड देयर कुड बी एडवर्स आउटकम आल्सो, और देयर कुड बी आल्सो इंक्रीज मोर्टेलिटी। दोनों ही कंडीशन में ये चीजें हैं, तो वी हैव टू वे प्रोज एंड कॉन्स इवेंट टू द व्हाट शुड बी द टाइम ऑफ इंट्यूबेशन, दैट डिपेंड्स ऑन द that 4 parameters that I told in the last slide. Next, readiness for extubation. How do we check whether patient can be extubated or not? The criteria for assessment is vital signs. We have to see the vital signs, age rated, heart rate, respiratory rate and systolic BPM, जो vital parameters लेते हैं वो देख लिया हमने। और वेंटिलेटर क्राइटेरिया, हमने उसको वेंटिलेटर से पीप उसको 5 सेंटीमीटर वाटर से कम रिक्वायर्ड है, प्रेशर सपोर्ट भी 10 से कम चाहिए, FiO2 लेस देन 40% पे मेंटेन कर रहा है, और देयर इज ए प्रेजेंस ऑफ एंडोट्रेकियल ट्यूब कप लीक, इसका कप लीक प्रेजेंट है। तो ये हमारे दी असेसमेंट, हम उसको एक्सट्यूबेशन के लिए पेशेंट तैयार है कि नहीं। नेक्स्ट, द फर्स्ट स्टेप इज दैट हम क्या करते हैं, स्टॉप फीड 6 आवर प्रायर और स्टॉप सेडेशन एटलीस्ट 2 आवर प्रायर। मतलब हम क्या करते हैं, एक्सट्यूबेशन से पहले बच्चे को फीड तो हम वैसे भी अगर मान लो एनजी ट्यूब से फीड दे रहे हो किसी को, तो हम उसको फीड बंद कर देते हैं और उसको जो सेडेशन है वो हमने पहले डिक्रीज कर दिया था, अब हम बिल्कुल 2 घंटे पहले एक्सट्यूबेशन से उसको बिल्कुल बंद कर दें। और हम क्या, हमारे जो टीपी ट्रायल पे पेशेंट है या सीपैप ट्रायल पे या मिनिमम सपोर्ट ट्रायल में पेशेंट, तो हम इसको ऐसी कंडीशन में ये दोनों बंद करके, मतलब इसको फीड बंद करके और सेडेशन बंद करके देन वी डू फॉर एक्सट्यूबेशन। नेक्स्ट, टी-पीस ट्रायल हम दे रहे हैं, द पेशेंट इज ऑन टी-पीस, तो वन एंड इज अटैच्ड टू द O2 सोर्स, एक सोर्स को ऑक्सीजन अटैच होती है, द फ्लो रेट इज एडजस्टेड इन सच ए वे दैट इट प्रोड्यूसेस अ कांस्टेंट मिस्ट इन द एक्सटेंशन ट्यूबिंग बोथ ड्यूरिंग इंस्पिरेशन एंड एक्सपिरेशन। ये आपने देखा होगा टी-पीस बच्चे रहते हैं, ये आपने देखो टी शेप ट्यूब है, बेसिकली इट इज दैट्स व्हाई इट इज कॉल्ड टी-पीस, इट इज अ टी शेप। आप दोनों तरफ भी देख पा रहे होंगे इसके जो ट्यूब्स हैं, तो ये है जिसमें एक एंड पर हमारे ऑक्सीजन अटैच रहती है। रफली फ्लो रेट इज मोर देन 3 times द मिनट वॉल्यूम, जो फ्लो होता है टीपीस में हम दे रहे हैं, दैट इज 3 times द मिनट वॉल्यूम। नेक्स्ट, CPAP and minimum pressure support that has to be done, work of breathing imposed by circuit, तो सर्किट का वर्क ऑफ ब्रीदिंग जो है उसकी वजह से डिपेंड ऑन द साइज ऑफ ET2। हमें क्या करना है, ET2 का साइज हम स्मॉल छोटा रखते हैं जिससे कि वर्क ऑफ ब्रीदिंग कम हो जाए। जैसे कि आपने देखा 3 to 3.5 मिलीमीटर को प्रेशर 10, अगर हमें प्रेशर सपोर्ट देना है 8 तो हमारा 4 to 4.5 मिलीमीटर होगा, मोर देन 5 है तो प्रेशर सपोर्ट हमारा 6 सेंटीमीटर चाहिए होगा उसको। दीज आर द रिक्वायरमेंट ऑफ द प्रेशर के प्रेशर सपोर्ट फॉर दिस थिंग, फॉर द ट्यूबिंग्स। नेक्स्ट, ET2 फ्लो रेट, ये हमारा रेजिस्टेंस है, अगर ET2 हमारा जो फ्लो रेट होगा तो रेजिस्टेंस, ये इसका चार्ट है कि हमारा रेजिस्टेंस हमारा बढ़ता चला जाएगा। नेक्स्ट, नेक्स्ट ब्रीथिंग,
Just a second, sir. It is hanged, I guess.
ओके। It shows the work of breathing in various modes of ventilation. These, I think, this is not much in this slide. It's showing the work of breathing in various modes, whether it's the pressure support, CPAP, TPs, or this if the patient is extubated. So this shows the increase this shows the work of breathing. अगर pressure support पर हमारा work of breathing कितना है और ये हमारा अगर CPAP है तो ये है, so this shows they are showing the pressure and rate, the work of breathing is the pressure rate at which the patient has to do the work against the pressure when the patient is on PS or when the patient is on the CPAP support or patient is on the TPs. Next, extubation procedure. How do we extubation procedure हम कैसे करते हैं? We have to do for keep equipment for re-intubation ready. अगर हमने किसी पेशेंट को हमने एक्सट्यूबेशन करना है तो हम क्या करते हैं, सबसे पहले द पेशेंट हैज टू बी लाई ऑन द सेमी पोलर और हाई पोलर पोजीशन एंड वी हैव टू एक्सप्लेन द प्रोसीजर टू द पेशेंट and pre-oxygenate the patient with a manual resuscitation bag and 100% oxygenation. The fourth step is the suction the patient mouth pharynx above the cup and re-oxygenate after suction. तो हम क्या करते हैं, पेशेंट को सबसे पहले हमने सेमी पोलर बेड पे लेटा के we have to assess, explain the patient को प्रोसीजर explain किया कि what we are doing to do. Then we have to pre-oxygenate. We have to give the oxygen with 100% oxygen. Then we have to do the suction of the mouth and the pharynx. Next. Extubation process is not that difficult. The suction the patient to clear the airway, as much suction कर दिया आपने, airway clear कर दिया. Squeeze the resuscitation bag while deflating the cup to force the secretion to the mouth from above the cup, or for suctioning, oxygenate and hyperinflate the patient, withdrawing the ET2 when pressure is built up in the lungs with the leak. आप ट्यूब को फिटिंग करके वापस नेगेटिव प्रेशर जो कि सिक्रेशन अंदर न जाए तो आप उसको बाहर निकाल सकते हैं। नेक्स्ट, administer the same fraction of inspired oxygen as before the extubation. आप उसको FiO2 पे सेम कंटिन्यू करेंगे। Monitor the patient while encouraging cupping and deep breathing and listen to the breath sound while particularly in the neck area. आपने कहीं उसको ना ट्रैकियल स्टोनोसिस तो नहीं होगी, ब्रेथ साउंड उसको ठीक से आ रहा है कि नहीं आ रहा है, you have to listen. Monitor the patient for change over the next 1 hour. For next hour, 1 घंटे के लिए मॉनिटर करेंगे। It may be desirable to obtain ABG measurement at this time to confirm the patient oxygenation and ventilative status is stable. एक्सट्यूबेशन करने के बाद हम उसका एक ABG करा के देख लेंगे कि पेशेंट इज मेंटेनिंग PO2 और PSO2 in the normal range or not. Next, पोस्ट एक्सट्यूबेशन हमारे क्या प्रॉब्लम आ सकती है? पोस्ट एक्सट्यूबेशन में हमारे में दिस जो नॉन वेंटिलेशन हम रख सकते हैं फॉर दोज विद हाई रिस्क ऑफ फेलियर। हम क्या करेंगे, हाई रिस्क ऑफ फेलियर रख सकते हैं। सप्लीमेंटल ऑक्सीजन बाय नेजल प्रोंग्स दे सकते हैं और फेस मास्क दे सकते हैं। फॉर मोस्ट ऑफ द पेशेंट हम ये करते ही है। मतलब क्लोज मॉनिटरिंग फॉर 24 to 48 hours to look for the airway obstruction or respiratory distress or hemodynamic instability. Next, ये एक मॉडिफाइड रेस्ली ग्रुप स्कोर है जिसमें कि हम लोग 3 पैरामीटर्स बेसिकली हम देखते हैं कि इंस्पायरेटरी स्टेटर तो नहीं है, चेस्ट में एयर मूवमेंट कैसा है, रिट्रैक्शंस कैसे हो रहे हैं, और ये तीनों जो पैरामीटर्स हमारे इंस्पायरेटरी स्टेटर है, एयर मूवमेंट्स हैं या फिर रिट्रैक्शंस, इन तीनों के डिफरेंट पॉइंट्स हैं। अगर हम देखते हैं कि अगर ये 7 से ज्यादा है तो हमारे को ये पेशेंट हमारे को इंट्यूबेशन ये है सक्सेसफुल हुआ है कि नहीं हुआ है। नेक्स्ट क्लिक करिए मैम, एक स्कोर है इसमें। नेक्स्ट क्लिक करिए। ये इसके बेस पर हम असेस करते हैं कि वेदर पेशेंट अगर ये स्कोर 4 से ज्यादा है तो देयर इज अ नीड फॉर एड्रेनल नेबुलाइजेशन, अगर 7 से ज्यादा है तो देयर विल बी नीड ऑफ री इंट्यूबेशन। इसका मतलब क्या है कि पेशेंट को री इंट्यूबेशन की जरूरत पड़ने वाली है। नेक्स्ट, तो पोस्ट एक्सट्यूबेशन एयरवे ऑब्स्ट्रक्शन हो सकता है। एक इंपॉर्टेंट चीज है कि बहुत सारे पेशेंट में आपने एक्सट्यूबेट कर दिया तो देयर आर चांसेस कि जो इंसिडेंस है इसका जो एक्सट्यूबेशन और पोस्ट एक्सट्यूबेशन ऑब्स्ट्रक्शन का दैट इज 2 to 25% केसेस में this is in the smaller age group children. If there is a size of a large ET tube है, कप ट्यूब में होगा, मल्टीपल अटेम्प्ट आप इंट्यूबेट करने के लिए है तो हो सकता है, एयरवे मैनिपुलेशन हो सकते हैं और इनएडुकेट सेडेशन इसकी वजह हो सकता है। These are the causes. These are the that could lead to the post extubation airway obstruction. Next, role of steroids. Steroids reduces the incidence of post-extubation stridor in children. These are not significantly reduces the re-intubation rate. हम क्या करते हैं? Usually, when we plan to wean, we give up 1 to 2 doses of steroid before planning. हम इसको wean off कर रहे हैं, तो हम क्या करते हैं कि this is to give to decrease the inflammation. कि हम उसको जो obstruction है, जो respiratory tract है, वहाँ पर जो inflammation होता है, उसको कम करने के लिए हम उसको पोस्ट एक्सट्यूबेशन जो स्ट्राइडर होता है उसको कम करने के लिए वी कैन गिव दिस स्टेरॉइड। द डोज रेंज इज 0.15 to 0.5 मिलीग्राम पर केजी पर डोज। वी कैन गिव इन मल्टीपल डोजेस और प्रेफरेबली 12 to 24 आवर्स बिफोर एक्सट्यूबेशन। जो मैंने आपको बताया था कि हम इसको 1-2 डोज 12 घंटे 24 घंटे से पहले हम इसको स्टार्ट कर सकते हैं, सो दैट द चाइल्ड कुड नॉट हैव पोस्ट एक्सट्यूबेशन ऑब्स्ट्रक्शन। नेक्स्ट, non-invasive pressure ventilation after extubation. An IV after extubation appear to be beneficial that improves the survival, lowers the mortality rate, that reduces the risk of nosocomial pneumonia, that lowers the incidence of septic shock and shortens the ICU and hospital stay. Because हमने अगर वेंटिलेटर से ले लिया तो हम उसको क्या करते हैं, कुछ देर के लिए हम उसको नॉन इन्वेसिव वेंटिलेशन पर रख देते हैं, जैसे कि हम CPAP पर रखते हैं, नेजल CPAP कर सकते हैं, ठीक है। वो these are things like that. Next, कॉम्प्लिकेशन ऑफ एक्सट्यूबेशन। मैंने आपको बता चुका हूँ लास्ट स्लाइड में भी 10 to 13% पेशेंट है इंक्रीज इन ब्लड प्रेशर। उनको हाइपरटेंशन हो सकता है, देयर कुड बी टैकीकार्डिया आल्सो, देयर कुड बी लारिंजियोस्पाज्म, laryngeal edema, there could be hemorrhage, or there could be trauma to the vocal cords, or there could be vocal paralysis also, or there could be vocal cord dysfunction. Next, extubation failure हो सकते हैं हमारे, that can, अगर extubation failure हो गया that can lead to the हमारे abnormal respiratory mechanics. There could be prolonged duration of mechanical ventilation. There could be hemodynamic instability, altered level of consciousness, inability to manage secretions. There could be anatomic abnormalities in upper airway obstructions, like there could be genetic abnormalities, metabolic perturbations, or fluid overload or unresolved infections. These are all related to the extubation failure. Next, this is the extubation checklist that you can check because it's not that visible. Next, the take-home message is the goal for weaning from mechanical ventilation is to liberal to the child, and it depends on every child is different, and the cause for the patient is being ventilated is different. So we have to assess every child differently and assess accordingly to in a pre-weaning stage whether the child could be given SVT or not. The ventilator as soon as he is sustained independent breathing. Predictive indices for weaning, they are not so predictive. जो आपको indices दिए हुए हैं वो उतने indices they are not so predictive. So हमारा सबसे अच्छा क्या है, clinical judgment, जो डॉक्टर वहाँ ड्यूटी पे हैं, जो देख रहा है, that is the best who should decide कि वो हमारे को वो डिसाइड कर पाएगा कि वो पेशेंट वेंटिलेशन से बाहर आने लायक, वेंटिलेटर से उसे हटाया जा सकता है या वेंटिलेटर सपोर्ट का कम किया जाता है कि नहीं. The doctor on that floor duty is the best person to decide. The spontaneous breathing trial is very useful for assessing the readiness, whether patient could be weaned off. The weaning modes are SIMV, PSV, and TPs are the common modes for the weaning of the patient. Mode for the patient. जैसा आपको बताया कि the TPs or CPAP and minimal pressure support trial are used for readiness to extubation assessment. कि हम उसको extubate कर सकते हैं, patient को नहीं कर सकते हैं. Post-extubation airway obstruction is the most important cause for extubation failure, and the use of steroid may help in reducing the incidence of post-extubation stroke. आपको दो important चीजें पता चलेगी कि हम we can start steroid 12 to 24 hours before we plan to extubate the patient, so that we can decrease the post-extubation airway obstruction. So this is very important, and I think next, I think the references have been taken from IIT textbook of pediatric ICU protocols. Next, I think that's all.
Thank you, Dr. Shio, for this
Jeevan,
excellent presentation.
Thank you, ma'am. I was in
And,
hospital, ma'am, for preparing for mock drill tomorrow, so I'm not able to.
Everyone is busy for in-house training and PICU patients. So let me see any questions. So I think there is no
I think people are not very much interested in online training, I think, ma'am. Only 72 participants are at this point of time.
No, actually, yeah, like last week there were, I think 400 or something. This week, the participants are less, but never matters. So
never, ma'am. We have to do this.
Interested.
Thank you, ma'am. Thank you so much. Thank you.
So thank you.
Thank you,
and
ma'am.
thank you for extubating the patient. So
Okay, thank you, ma'am.
everything is good in the last. So, and thank you all the participants for your patient listening. So we end our session here, and tomorrow again we have some important topics like management of shock in children, MIS, multi-system inflammatory syndrome is a very common presentation of pediatric COVID, very important topic. Then overall PIC management. So please join us tomorrow at 12 noon. So thank you all the participants.